This is Professor Antonio Volvena from Barcelona, Spain, and the topic I'm going to give you is about the new model which we really think that might be a very useful for clinical psychiatry and for understanding our patients. The outline, the contents of my talk will be divided in three parts. First, I will review for you several facts and figures which might be relevant for you to know. Second, we shall review some of the mechanisms involved in that model. And third, I shall present you the phenotype, which is the model I'm going to offer you. All that story started as soon as in 1988, when I was working at the Hospital del Mar in Barcelona, where I was seeing my patient with anxiety, phobias, so a typical outpatient psychiatry. But one of my colleagues, which is Dr. Duro from rheumatology, in the same medical record which you shall see in this paper, he put a stamp on my patients, on the medical record of them, about hyperlaxity. He was studying that topic, but I was surprised, and both were surprised at how big was the coincidence between them. So a lot of my anxiety patients really were identified as hyperlaxed by Dr. Duro. The coincidence was so strong that we decided to publish that in The Lancet, and they admitted immediately the paper. About 70% of my anxiety patients show these features. Ever since, this is what I have been confirming all along these years. So the next patient you see with panic, you can check whether they meet these criteria, which I will show you. The other way around, so how many of the Ehlers-Danlos, which is the old name for hyperlaxity, meet anxiety criteria. Lifetime is not as high, but at least between 30 and 40% of hyperlax people show some features of anxiety. But be aware that both conditions are quite invisible. These are the typical Byton criteria. So the fifth finger hyperextension with the palm flat on the floor, the thumb over the forearm more than parallel, the elbow hyperextension, the knee hyperextension, and also the palms flat on the floor. This should be trained before you examine that. It's interesting that you receive some little training for that, not too complicated. Other manifestations are this flying hand, these funny postures on the hand, the bluish glare or dark sclera, stria, the scars are hypertrophic or even properly keloids, and especially among women, not among men, the ecchymosis, which is easy bruising. But very often this is very unnoticed. But from the beginning, when Ehlers-Danlos, which were two dermatologists who described this condition first for the hyperextensive skin, all this has gone from dermatology to rheumatology, but just in the 80s we start to see chronic pain. We managed to publish almost in the 80s the close relationship with anxiety and phobias and somehow depression. But ever since, dysautonomia, gastrointestinal dysfunction, very, very common, mast cell activation syndrome. In fact, this is really a systemic illness which produces a lot of disability, has a lot of comorbidity, and we need to be aware of this condition. But don't forget that these symptoms, these manifestations, are not just sequelae of the joint problems, are part of the same condition. Roughly speaking, 1 out of 5 people show criteria of this spectrum, which is now how it's now known, and 1 out of 3 are women. But what is the classical form of hypermobility, which is the hypermobile joints, dislocations, sprains? Now we know that there are many other symptoms which are much more common, because the severe forms of Ehlers-Danlos, there are 13 forms, are really very rare. But this condition I'm showing you are quite common, as I mentioned to you, because not just joints, but POTS, low BP, fatigue, anxiety, weak pelvic floor, chronic pain, IBS-like symptoms. But for our interest, anxiety and sleep problems and medical unexplained symptoms are extremely common. In this phenotyping from an American group, these are the typical classic symptoms: skin, hernias, joint pain, etc. But we know that all that you can see at your right-hand side, so migraine, this Raynaud syndrome, especially gastrointestinal, which is the most common of all, tethered coat, this bleeding. But look at this dysautonomia and POTS, anxiety, depression, autism spectrum disorder. I would add here the ADHD, and also chronic fatigue and also pain like fibromyalgia. All these are much more common than the original ones. So, but what is our interest in psychiatry? Is because a lot of our patients, if you check them, they are showing these features. And anxiety, as I already mentioned, is 70%. Depression, when it's comorbid, again, is up to 70%. Eating disorder, autism, ADHD, at least half of them show that criteria. Personality disorders, especially borderline, when they have anxiety, they also have these hypermobility features. And psychosis, so schizophrenia and bipolar, we have published 2 papers in which those schizophrenics and bipolar comorbid with anxiety, they also show a high percentage of hypermobility. Concerning conversions, it's 70%, I shall show in a slide later on. So therefore, be aware, psychiatrists, neurologists, psychologists, it's very important that you pay attention to this. At least half or more than half of our patients have this particular anatomical. What are the mechanisms? Well, from these joint things to the brain to our behavior. And then what I can tell you is that from the perception point of view is very important, less proprioception, but more interoception, more exteroception, and more dysautonomy. They are very, very sensitive, these patients. Second, we have plenty of, I shall show you some data of neuroimaging. Their brain is really somehow different, but we have plenty of clinical and epidemiological data that confirm this relationship. They have more sensitivity, but they also suffer from more anxiety and more fear, and they are, at the end, more warriors, but also more warriors. Several evidences I want to show you. First, we just show that dogs with hypermobility also had some anxiety features. They were more emotionally aroused. The emotion processing in these patients is really somehow different. We work with a British group and with a Spanish group. This is the Spanish part. It was 2015. The hippocampus and were hyperreactive. Also in functional imaging, we also showed that there were some differences in how the brain of these subjects respond differently. And also quite interesting is this paper together with a British group of Dr. Critchley, in which we show that state anxiety, hypermobility, and interoception are closely related to each other. Well, finally, early this year, this British group has publish a more detailed analysis of how these joint hypermobility brains respond different when they have anxiety, and what is the role of amygdala and issular cortex. So therefore, there is no doubt that this condition, formerly just a skin problem, now we are aware that there are some central nervous system features which deserve our attention. Well, trying to put together all this information, what we did is to really collect the symptoms and the signs of the experiences all along these years, and we have developed this neuroconnective endophenotype. And what was the aim of this? Was just to put together not just body or mental, but both at the same time. Also, we were interested in see that all these subjects not always have just bad problems like pain. They can be also very good in sensitivity, in being able to fight. So there are several features which are not only negative, and we try to collect both positive and negative dimensions. And this is useful not just for the professional in order to collect this information, but also for the patient who realizes a lot of these things. And this has been published. But let me show you each of these parts. First, the sensorial sensitivity. For instance, olfactory sensitivity, we have published extensively about that. Sensitive to visual and auditive stimuli, for instance, misophonia, sighting, dyspnea, dizziness, dysphagia or choking, palpitations, some pains and urological and vaginal pains, and joint pain, of course, but also intolerances or enhanced sensitivities to weather, to drugs, particularly psychotropic drugs. They might be quite intolerant, chemicals, or even head and cold. Second, the body signs. What do I mean by that? Somatotype, we published that very early. Dark sclera, as I mentioned, easy bruising, hypertrophic scars or keloids, dysautonomia, dysesophageal dyskinesia, sprains, dislocations, spistroptosis, prolapses, bruxism, very, very common as well. Third, not just symptoms, but that conditions, and particularly the gastrointestinal ones. Irritable bowel is really very common. Dysfunctional esophagus, POTS, dizziness or unsteadiness, chronic fatigue, fibromyalgia, migraine, dynias like vulvodynia or glossodynia, the temporomandibular dysfunction, hypothyroid, asthma, mitral valve prolapse, and this intolerance I was telling you about. We also saw that by model responses like fight and flight, oneself, others, loss of control, over control, we all have this access. But we realize that these subjects very often tend to go in the extremes, or one or even both. So the red part was very often visited by them. This is very useful to approach the psychotherapy with these patients. And the psychological dimensions was the increased interoception and also the exteroception. We have studied the meteorosensitivity, the social perception. So if you are really hated, or you are left apart, or you are abandoned, these patients are very sensitive to that. The depersonalization is quite common, not always told. The very high loss or grief sensitivity, they tolerate very poorly the losses. Anticipatory anxiety is really paramount. But together with this, they have a very high positive confrontation. So they have a high ability to deal with real acute problems. They are very, very good warriors, which is contrasting because they have at the same time anticipatory anxiety. When they go into the fight, they are really brilliant. Therefore, they're very highly resilient, and sometimes you can see people with very high achievements in all fields. And of course, all the diagnoses have to be checked. And so therefore, this endophenotype for our group is, for our part, which is the neuropsychiatry part, is anxiety and fears, which is perhaps the most important sign, but also ADHD, autism, eating disorder, this brain very gifted for quarreling, for war, anticipatory anxiety, this vulnerability to losses, but very high performance. And all the axes are a lot of sensitivity, both interoception, whereas proprioception tend to be poor, dysphagia, bloating and pain. Concerning somatic signs, to review ecchymosis and sprains, scars, allergies, fibromyalgia and fatigue, and the somatic conditions, especially the gastrointestinal ones, but also prolapses, hernias, hypermobility, of course, muscle activation, temporomandibular, and some different, very uncommon cases, these aneurysms, and of course the polarities, this tend to be in the extreme. All this has been published in this book in English about anxiety. We collected all this information in a paper in which we managed to validate this questionnaire about the neuroconnective endophenotype, because this has to be collected with reliability and validity. And a lot of this information just is answered by the patients, but of course the clinical examination of hypermobility, and the diagnosis of the medical and the psychiatric problems has to be done by a professional. And these parts are all included in this questionnaire, which I think are very useful for our practice. Let me end up by this recent study published applying this neuroconnective endophenotype to a sample of patients diagnosed for neurologic functional disorder, formerly the hysteria or conversive disorder. Well, compared with controls, all the dimensions of the neuroconnective endophenotype, which is the sensory sensitivity, the physical signs and symptoms, the pain intensity, the pain location, these behavioral polarized dimensions, and the psychopathological dimensions, all of them were more significantly more present among these conversion or neurologic functional patients. But if we check the presence of joint hypermobility, which is one of the features of this endophenotype, we can see that 70% of these conversion disorder patients, 70% show features of this hypermobility spectrum, whereas only 33% did not show. Therefore, please avoid the diagnosis of hysteria or conversion without assessing this hypermobility, or even better, the neuroconnective endophenotype. To summarize, first, the prevalence of hypermobility spectrum, the old hypermobility syndrome, is very, very high among anxiety patients, but also significantly high among eating disorders, ADHD, and autism, and probably others. For instance, when schizophrenia is comorbid with anxiety and bipolar, also they are more hypermobile. Second, don't forget this somatization, which is often a wrong diagnosis of these patients. Avoid diagnosed somatization without assessing hypermobility. Third, there is evidence that the presence of EDS in 70% of conversion disorder patients. Therefore, please avoid that diagnosis before assessing this. Therefore, my offer is that psychiatrists and psychologists should learn how to assess hypermobility spectrum, or even better, the neuroconnective endophenotype. Thank you very much for your kind attention, and I remain at your disposal if you want to contact with me. I will be happy.
Let me introduce myself. My name is Leah Tarupchina. I am clinical audiologist and ENT doctor. First of all, I would like to thank organizers of a conference for the opportunity given to me to take part in a work of this international conference. And I would like to share with you my experience to work with children who complain on sudden sensorineural hearing loss, but rarely have a normal hearing. Children starting from preschool age simulate hearing loss much more often than is commonly believed. And many doctors believe that children don't simulate hearing loss at all, which is of course a major misconception that leads to unsuccessful treatment and misleading of the parents. And it leads also to disappointment in the potential of medical hearing restoration in many cases of truly sudden onset sensorineural hearing loss. I can say that many ENT doctors even afraid children who complain on sudden sensorineural hearing loss because the treatment will not successful. And why it is happening? Because many children simulate hearing loss. Sensorineural hearing loss of any severity and even deafness can occur in any part of the auditory analyzer from the cochlea to the brain cortex. And the sensorineural hearing loss rarely can start at any age, even if the pathology is congenital or genetic. And it can be rarely acquired sensorineural hearing loss, the cause of which is unknown at the first visit to the doctor. In the clinical audiology, there are two large groups of method of hearing examination: subjective hearing tests and objective hearing tests. Subjective hearing test methods require some cooperation with the patient, require some answer from the patient, and results depend on the patient. Those are tuning fork tests, speech tests, pure tone threshold audiometry, speech audiometry for adults and children. Objective methods of hearing examination don't depend on the patients. Those are impedancemetry and registration of various classes of otoacoustic emissions and registration of various classes of auditory brainstem evoked potentials. And in cases of actual hearing loss, the results of objective and subjective tests correlate. When hearing loss is simulated, the data from objective hearing tests are normal, but the results of subjective methods contradict each other and the data of objective methods. Of course, in every case, we should use both groups of method, but it is not always happened. And for example, when we provide pure tone threshold audiometry, we can observe unreliable, slow, fluctuating responses. It is very heavy to provide pure tone audiometry in cases of simulation. Speech audiometry in a game form for children, it is depend on the age sometimes of child. We can observe normal hearing if the child naive or different answers, conflicting answers, and tuning fork test also we can observe conflicting answers because the children have no idea about tuning fork test. And what is the reasons for hearing loss that doesn't exist? First of all, it is an imitation of an adult who is important for the child. After that comes simulation of a deafness. It is most often reason, and conversion hearing disorder or so-called psychogenic hearing loss. As you know, the small children like to copy bad behavior or unhealthy behavior, and imitation of an adult who has a hearing loss and very important figure for the child, for example, a father who is deaf in one ear, is common in preschool age children, and is quite innocent in nature if you don't take, of course, the strong fear that the parents feel. Simulation of a deafness. The child consciously decides to complain about hearing loss. Children who simulate the hearing loss begin to complain of deafness, usually unilateral, in order to gain some kind of advantage. Complaining about sudden unilateral hearing loss is extremely frightening for parents who shift attention from their own problems to their child, and in addition, feel a sense of guilt for failing to prevent it. Children typically simulate unilateral deafness to stay connected and to control the situation. Bilateral hearing loss is less common. After an unsuccessful course of treatment of unilateral sensorineural deafness, the cause of which remains unidentified, often due to the doctor's blindly faith in the data of subjective methods of examination, the excitement goes down and the parents come to terms with the situation. Then the other ear goes deaf and the child admitted to the hospital again. The mental abilities of some children should not be underestimated, as we quite rightly point out that not all ENT doctors are well versed in hearing pathology, so the doctors can be led by the nose for a long period. This kind of simulation is often based on a problem that is stressful for a child. Therefore, it is crucial to identify the cause of such a child's behavior. And the most common reason for simulation is attention-seeking behavior when the child is experiencing problems in the family. Therefore, when collecting a history from a child complaining of sudden onset hearing loss, unimproved by objective hearing tests, it is essential to thoroughly investigate the presence of a stress disorder. Among the reasons that prompt a child to report a sudden onset unilateral deafness, according to our observations, divorce of parents is the most common, and it is extremely stressful for any child. Divorcing parents, at least concerned about their children's psychological well-being and have no idea how traumatic this can be for the young and unexperienced souls. According to our data, 60% of all children admitted in our hospital with complaints of sudden unilateral hearing loss will simulate hearing loss, mainly due to the divorce of their parents. And after the divorce, the situation typically doesn't improve. For example, the child may witness how the father is insultingly happy in his new marriage and unhappy mother. In this regard, I'd like to quote the words from the essay Rules of Life by the great physician, teacher, writer and public figure Janusz Korczak. The grief of parents for a child is heavier than their own, and life is given to everyone according to their strength, And rest assured, it is no less difficult for a child than for you, and maybe even more so because he has no experience. And don't be fooled if both caring parents visited you together with the child. It doesn't rule out divorce proceedings. Divorce of a parents is number one. And reasons for simulation of hearing loss include jealousy towards younger family members, scolding for bad grades and while doing homework, inflated expectation of parents for school performance, problems at school leading to reluctance to attend, aggressive classmates, fights. In this case, both participants can simulate hearing loss. Poor academic performance, fear of exams, heavy teaching load, stratification of children by social status and income of parents. And conversion hearing disorder, so-called psychogenic hearing loss, is a condition their child sincerely believes in his hearing loss occurs as a result of exposure of severe shock or chronic mental trauma in persons with an overly excitable central nervous system. In such cases, emotional dysfunction unknowingly converts into physical symptoms, but there are no organic substrate of the lesion. The results of objective methods of hearing examination are normal. It is a group of children with increased suggestibility. It is not the severity of a situation that plays a role, but the person's increased sensitivity and inability to resist stress. The causes of conversion hearing loss may be an unhealthy psychological situation in the family. A divorce of parents is the leading cause, conflict situation at school, difficult treatment, numerous operations, excess weight in adolescence, aggressive neighbors, shocking impressions, Munchausen syndrome in the mother of the child. I have in my practice one such case. And I can say that the childhood, often impressionable child, cannot be happy. And complaints of hearing loss can also be a manifestation of a hysterical personality disorder, which is subsequently developed into a psychiatric disease. We observed situation where it came to the need for hearing aids. And here, a very interesting moment we can observe. If the child has a hysteric disorder, the entire school will know about the presence of hearing loss in a child, and this child will sit pompously in the front row and accept condolences. And what are the reasons for delayed diagnostic of simulation or conversion hearing disorder? First of all, it is a blindly faith of the doctors in the data of subjective hearing methods of hearing examination. Second point, examining a child in the absence of parents, even if they accompany the child, which does not allow one to grasp the peculiarities of their relationships and contributes to the growth of dissatisfaction with the medical services and deprives the doctor of the opportunity to clearly demonstrate conflicting research results to the family. And unfortunately, the specialist indifference to the child. Sometimes it happens unwillingness to establish contact with the child, ask the child a little bit about school, studies, and so on. And what can I say in conclusion? When we see first time a child with complaints on sudden sensory neural hearing loss, first of all, we should think about simulation. And sometimes it is necessary to thoroughly collect the anamnesis and provide a targeted analysis of a life situation. It is necessary. And sometimes a double bottom effect occurs. Parents admit that the child has experienced stress and point out the problem. For example, a sudden unplanned change of place of residence. But upon further questioning, they admit that they are going through divorce. And the line between simulation, conversion, hearing loss, and hysterical character is quite thin, and it is a reason for consultation with psychiatrics and psychologists. But I should be noted that parents typically react negatively to information about their child simulation due to underlying problems and are reluctant to consult psychologists and psychiatric. Thank you for your attention.
Добрый день, меня зовут Ягудин Дмитрий Рустамович, я клинический психолог, доктор психологических наук и представляю вам новую интереснейшую тему, которую сегодня буду с вами обсуждать и предоставлять, нейроинтуиция как новый принцип мышления человека.
Good afternoon, I'm Dmitry Yagudin. I'm a clinical psychiatrist and doctor of psychological science. And I'm going to present you a new phenomenon as a neurointuition, as a neurophysiological mechanism, and I'm going to tell you about this.
Так, сейчас. Окей, я прошу прощения, что разговаривал с вами с переводчиком, поэтому буду очень краток и постараюсь донести всю суть. Тем не менее, вы сможете познакомиться в статьях более подробно об этой информации, потому что при разработке данного феномена было переработано порядка 400 научных изданий за последние 15 лет, которые касаются мышления человека, интуиции и нейроинтуиции. Интуиции и мышления аналитического.
I'm sorry for using the interpreter to talk to you. So that's why I'm going to be short in my thesis about my topic. And if you like, all the materials are provided and you can find them by links here. And it's all my observation where I used over 400 scientific publishings, and I was searching for them and investigating them for 15 years. And now I'm going to talk about intuition and analytical thinking.
Спасибо. Прежде всего, чем начать эту тему, я должен вам рассказать, с чего появился такой запрос, так как я увидел новую систему мышления, когда работал более 15 лет в службе спасения и очень много участвовал в экстремальных ситуациях, где приходилось видеть, как люди спасаются сами, спасал их сам и увидел один очень феномен. И увидел этот феномен.
I would like to start with where this inquiry appeared from, where I saw this for the first time, this new system of thinking. It happened to me when I was working in the Ministry of Emergency Situations, and I was working in this rescue service, and I was saving people, rescuing people myself, and I saw how it was happening. And it's when I saw this phenomenon, I noticed this phenomenon.
Yes, спасибо. И я разделил на три типа мышления человека, которые попадают в экстремальную ситуацию, и на те решения, которые они принимают во время ее. Я участвовал в этом сам и видел, как это происходит. Их всего три типа. Когда человек попадает в экстремальную ситуацию, он мобилизирует все свои ресурсы. Мы о них с вами прекрасно знаем, у него учащается сердцебиение, выделяется адреналин, но тем не менее до действия доходят только три типа.
Altogether, there are only three types of thinking when a human being appears to be in extreme situation, in a situation of emergency. I saw how it happened when I was working there. So there are only three types of thinking which we can have. Although any person in this extreme situation mobilizes all their resources, but I can describe these three types.
Okay, yes. One types we can see this, и мы называем это посттравматический синдром. Это когда человек застывает в ситуации, когда стресс-уровень доходит до сильного, объемного, до максимального предела, и он ничего не может делать. Мы называем это синдром замирания, когда человек встал. У него включается логическое мышление, при котором он пытается анализировать ситуацию и бездействует. Он замирает. И таких, кстати, очень намного проще было спасать. Второй тип – это интуитивный, когда у человека начинается паника, он включает эмоции, он включает свою интуицию, быстрое решение, но так как не может найти выхода из ситуации, и тоже попадает в посттравматический синдром, и часто с такими было сложнее что-то решать. И есть третий тип. Все, сейчас про третий расскажу потом.
Yeah, the first type, it's post-traumatic syndrome. This person gets stuck in this stress situation, and this syndrome is of getting stunned in this situation. So they cannot do anything about it. They cannot think, they cannot move, and things like that. And actually, these people are the easiest to rescue. The second type is intuitive type. When this person turns on their emotions and quick decisions, but they still cannot do anything in the very difficult or extreme situation.
Yes. And третий тип, который я видел и в котором участвовал сам, видел это у своих коллег, когда человек начинает действовать и принимать решения настолько быстро, высокоэффективно, как будто бы он уже видел ситуацию, как из нее выйти. И он выходит из этих экстремальных ситуаций, стрессовых, и вместо того, чтобы его органы чувств закрывались и не понимали ситуацию, они активируются и позволяют ему делать те решения и задачи, которые, как кажется, с точки зрения биологии, психологии и в целом понимания человека, было бы невозможно. Я сам лично видел, как маленькая женщина в 70 килограмм выкидывала огромные вещи, килограмм под 100, люди перепрыгивали огромные расстояния и выживали в сложных ситуациях. И мне было всегда интересно, почему так? Кто-то принимает решение так, а кто-то так. Как работает мозг?
And the third type, I saw this type personally with my colleagues who were acting in these extreme situations. It's when suddenly this person starts acting quickly and very effectively. And all his organs of this sensation, instead of closing up, they open, and he starts thinking very quickly, and as if this person understands how to act, how to behave. And you've got an impression as if they saw it before, they did it before, although they haven't. They have never seen it before and done it before. But they do it from inside. And for example, I saw a fragile woman who was throwing out very heavy things and she knew what to do. Or I saw other people jumping over some big distances in order to save themselves or other people. So this type of reaction is the third.
Спасибо. И в этот самый момент мне стало понятно, что это особый тип мышления, который я бы назвал, сначала я назвал его динамичным типом мышления, потому что логика и интуиция помогают решить задачи и уйти от проблем. А это то, когда я чувствовал на себе, ты точно знаешь, что ты выйдешь из этой ситуации, и условно как спортсмены, либо кто-то или какие-то еще люди, ты видишь все в замедленном кадре и решаешь эти ситуации. И дальше мне стало интересно, почему у нас этот тип мышления включается только в экстремальных ситуациях, да, когда нас поднадавили, как его можно было бы в человеке каким-либо образом включить, когда мы ставим себе задачу не уйти от боли, а решить какую-то жизненную ситуацию, допустим, поставить цель, задачу, да, какого-то высокого порядка и идти к ней точно, точно таким же путем.
So, second. At this very moment, I realized that this special type of thinking is a dynamical type of thinking, as I called it, when you know for sure how to act and you know that you are going to survive and get out of this situation. It's like being a sports person, and it's like you see this all in a slow video where you understand and realize what to do. And it was, I started wondering, it was interesting for me at that moment, why this type of thinking turns on only in extremal conditions, and how is it possible to activate it in different conditions when necessary? How can we make this mechanism work when we want to?
Yes, thank you. And I сделал огромное количество исследований, прочитал всего, и сегодня я расскажу, я назвал этот тип мышления нейроинтуитивный. И здесь я вам сформировал уже три типа мышления, но пойду дальше, да, в которые вы можете прочитать. Нейроинтуитивное мышление – это мышление, когда наша логика и наша интуиция ищет и закрывает стресс-фактор, который она поставила себе как впереди для решения задачи, то есть динамика, а не как уходить постоянно от боли, припрятаться, чего нам сейчас не хватает в современном мире. Прям можно вкратце.
So I've made lots of investigations, and I will call this type of thinking neurointuitive. And it's when our logic and intuition looks for the solution of the situation. Instead of closing up from pain, this type of thinking allows us find the solution of it.
Спасибо. Здесь я вам представил, да, типы мышления, чем они отличаются и как человек принимает решения. Но, тем не менее, попадем дальше, потому что времени у нас всего 20 минут, мне хотелось бы до конца вам показать. Далее мной было изучено о том, как человек принимает решения, какими регионами мозга, как это все происходит. И я начал изучать, как применить эту модель мышления и сохранить не в экстремальных ситуациях, а в решении каких-либо задач, которые мы себе ставим.
So here I gave a list of types of thinking and how they're different. You can see them. But I'm going to be brief, and I'll tell you how I was thinking of how the person makes decisions, quick decisions, and which parts of brain do people use during making these decisions, instantaneous decisions. And so here I'm going to tell you about this.
Окей. И увидел один и тот же смысл, что когда человек взволновывается какими-то стресс-факторами извне, у его надпочечники выделяют адреналин и более 50 гормонов, учащается сердцебиение, повторюсь, но кто-то начинает действовать и решать задачи, а кто-то уходит в мир образов и занимается этой ситуацией у себя в голове. И задача была понять, как его вернуть и какие стресс-факторы в жизни нас постоянно заставляют взволновываться, отвлекаться и не концентрироваться на задаче, подобно той, которая происходит в экстремальных ситуациях.
So one and the same meaning, it's one and the same meaning when a person is worried. When we get worried, our body start processing special hormones, and some people just find get all their forces to get concentrated, and they look for solutions. They start thinking, looking for solutions, and the other person, for example, can vice versa. They go to the world of images. So my task was to understand which factors can distract us from logical thinking, which factors can make us go into these images, so that we could use all our possibilities and capacities in any normal situation, like in an extreme one.
Yes, thank you. And я увидел один фактор. Человек, который ставит себе задачу на решение каких-либо вопросов, часто взволновывается при общении с окружением, с людьми. Мы живем в социальной среде, а общение с другими людьми у нас занимаются зеркальные нейроны. Мы постоянно со скоростью 120 метров в секунду общаемся с другими людьми. И как мы с вами уже знаем, эмпатия и зеркальные нейроны взаимосвязаны, и это один механизм. И по какой причине человек, который ставит себе цель и задачу и импонирует ей, теряет на пути к ее решению, в отличие от экстремальной ситуации, когда у него все мобилизируется к ней, ту самую эмоционально-физическую концентрацию.
Mm-hmm. So I saw one factor where a person who has a task to solve any problem, often this person gets worried during communication with other people. And mirror neurons are those responsible for our socialization and communication with other people. So empathy and mirror neurons are linked together. So that is what brought me to this idea, to use this when we want to solve any situation in normal conditions, not extreme ones.
Yes. И мне стало понятно, это те самые зеркальные нейроны, когда наша мимика считывает всех вокруг, когда мы идем, для того, чтобы быть в безопасности, активируются те самые зеркальные цепи, которые активируют эмоционально-моторные зоны, и люди в этот момент неосознанно проведено огромное количество исследований, когда мы просто идем по улице, да, у нас бывает, что учащается пульс, ускоряется шаг, то есть мы выходим из того паттерна движения и паттерна мышления, который перед нами стоял. То есть человек рассеивает свое внимание и взволновывается, а потом сам теряет концентрацию и не может, как в той ситуации, повторюсь, экстремальной, выполнять те функции, которые ему необходимы.
Mm-hmm. I understood. It was the same mirror neurons when we scan and we read facial expressions and mimics from people's faces. And our brain, our psychomotor parts of brain get activated. Our heartbeat gets quicker, and we start worrying. When getting worried, we leave this our typical pattern of thinking. When a person worries, they leave their usual focus of attention. They stop being concentrated. And that's how this happens, how we leave the zone where we are concentrated when solving
Yes.
tasks.
Yes. And стало понятно, что это состояние человека очень похоже с тем же состоянием, которое происходит в экстремальной ситуации, просто он находится в более меньшем потоке, но постоянно. Там он находится концентрированно, а здесь находится постоянно. И мы все с вами знаем, что самое полезное и нужное для человека – это другой человек, но самое вредное для человека, что может его просто уничтожить, это тоже другой человек. И пока человек не научится концентрировать и возвращать свою эмпатию через зеркальные нейроны обратно к своей задаче, и пока он рассеивается, он постоянно будет расконцентрироваться, да, и впадать либо в аналитическую составляющую, либо в интуитивную, выдумывая себе какие-то проблемы. И это очень отвлекает и забирает огромное количество сил.
So it's all about different level of concentration. So in extreme situations, it's much higher. When it's a normal situation, but we get worried, it's the same. We leave the concentration zone. We cannot get concentrated or focused, but it's the same pattern. It's the same situation, and it works in the same as the same mechanism. Because actually, the most useful for anybody is another person, and at the same time, the most harmful for us can be another person. So that's why when we start worrying and lose concentration, we leave our normal focused state. So that's why we sometimes leave this our concentrated state, and sometimes we come back into it. So the task here is to learn how to manage this mechanism with yourself, how to apply this to your own self, how we can make ourselves concentrated again, come back to our empathy.
Yes. And тогда было понятно и была выведена формула нейроинтуиции, когда мы ставим доминанту, эмоционально-логическую доминанту на решение какой-либо задачи, на которую у нас прямо сейчас нет ответа, и начинаем активно принимать участие к ее разрешению. И можно было отследить, как человек уже нейроинтуитивно отбирает необходимых себе людей, будь то в бизнесе, будь то в спорте, у меня свой боксерский клуб имеется, будь то в спорте, с кем ему взаимодействовать, а с кем ему нет, не теряя постоянной концентрации. А это бич по проблеме современного века.
So I was able to conclude, to come to a formula of neurointuition. It's when the emotional dominance is put on the first place, and we actively try to solve this task. So that's when a person intuitively starts, for example, actively and using their intuition, they start selecting necessary people for whatever, for business, for any things that these people do. For example, I myself have a boxing club where I intuitively know which people to employ, which people to work with.
Yes. And данная формула содержит 3 фактора. Это биологическая адаптивность, психическая эмоциональная устойчивость и постоянное зеркальное лидерство, с которым мы взаимодействуем с миром, будь то в соцсетях, будь то в мире, который постоянно нас сбивает. И все это умножается на индивидуальную скорость нервного узла человека. И те результаты, которые я стал получать от людей, с которыми мы ставили задачи и шли, это просто поразительно.
This formula includes three factors. The first is biological adaptivity. The second is psycho-emotional sustainability. And the third is a constant mirror leadership. So it's like in everyday life and or in social networks. And it's all multiplied on individual speed of neurotic knot. When I was noticing that and I was observing people having this all, I saw that results were astonishing.
Yes. And this new, это новое мышление, в отличие от интуитивного и логического, который решает задачи тут и сейчас, это мышление человека, который решает задачи для того, чтобы материализовать, либо получить ту задачу, которую он себе ставит, которая на данный момент времени не может решиться теми средствами, будь то интеллектуальными и физическими, которые сейчас он имеет. Но именно при помощи интуиции и зеркальных нейронов, то есть своей логики, интуиции и общения с людьми, он находит ее решение очень четко, точно и быстро.
This new type of thinking, unlike intuitive type or logical type, which solve problems here and now. They are directed to solve problems here and now. This type of thinking solves the tasks or solves problems which are impossible to solve because here and now, because it's either not enough meanings intellectually or physically. But using this type of thinking, anybody, this person who uses it, is able to find the solution and get to the result anyway.
Yes. И это совершенно иная концепция в психологии взаимодействия с другим человеком, потому что эта концепция помогает ему выйти из той парадигмы мышления и прийти к новым жизненным результатам. И мы знаем, что самый лучший естественный процесс нервной системы человека – это адаптация. Когда я совершил какое-либо действие, которое раньше не делал, решил задачу, я адаптируюсь, и у меня меняется личность. То есть я прохожу какие-то кризисы. Это то, как было в МЧС. И нервная система человека при движении вперед работает точно так же, просто более в маленькой потенции. Основная задача не создавать большой стресс, а создавать микростресс, который полезен для того, чтобы человек постоянно шел, менялся и реализовывал свои задачи.
Mm-hmm. And this is a completely different conception of collaboration with other people. And this type helps to get out of a usual or old paradigm of thinking. And this important way of thinking is adaptivity. When our neurotic system gets adapted, when moving forward, it really needs some micro stresses so that it trains to get adapted to them. It's just micro stresses which do not affect us badly or do not harm us, but they help our brain to learn to think in this new way.
Да, дамы и господа, я попрошу прощения, что задержал свое выступление. Я буду дозавершать. Если кому интересно, обращайтесь. Я с удовольствием пообщаюсь, поделюсь с вами результатами. На данный момент времени мы их активно делаем. Скоро они будут представлены, но хочу повторить, что что то, что делает человек в экстремальной ситуации, иногда это поражает, и невозможно это объяснить, да, вот, но такое же человек может делать, когда ставит себе амбициозные цели и шаг за шагом их решает, тем самым адаптируя себя в новом понимании и раскрывая свои таланты. Это некий другой фокус мировоззрения. Спасибо.
So ladies and gentlemen, I bring my apologies for being a bit too long, and I'm going to finish now. So if anybody is interested, I'm happy to share my results, which I have now, and I'm doing some more research, and I will always be happy to share with you. And all my results are going to be introduced. But what I really want to say is that what any person, any human being can do in extreme situation, they can do the same in normal situations by adapting and training their neurotic system. And if we train ourselves, our brain, to adapt and to be able to survive these little similar situations, we'll be able to solve very ambitious tasks of ours. Thank you.
Good morning, ladies and gentlemen. I am deeply honored to speak before such a distinguished audience, and I am truly excited about this opportunity. Although my English is not perfect, I practice it every day, and I will support myself with notes during the presentation. Thank you very much for your understanding. Today, I will present pioneering research on brain kinetic as an innovative therapeutic approach that supports post-traumatic growth in children and adolescents. For several years, I have been researching the influence of brain neuroplasticity on post-traumatic growth in young people. And I use the brain kinetic method as an innovative therapeutic tool in this field. At the end of presentation, I will invite you to join me in a few simple brain kinetic exercises which will help you experience the method in practice. For this reason, I will forgo the traditional question and answer session because I do not yet completely confident speaking English. I kindly ask for your understanding. I will be happy to answer any question by email after the conference so that I can provide precise and talk responses. Research background and objectives. This study seeks to answer three key questions. First, how can brain kinetics support post-traumatic growth in young people? Second, which cognitive and emotional mechanisms are most effectively influenced? Third, does the method enhance self-regulation, concentration, and psychological resilience in trauma-affected youth? Please show this slide. The next slide continues this point. Please show you. Post-traumatic growth. Post-traumatic growth, or PTG, refers to positive psychosocial and personality transformation that result from constructive processing of trauma. In children, PTG depends on the developmental stage, the capacity for reflection, and the individual adaptive resources. Brain kinetic as an innovative method. Brain kinetic integrates motor activity, cognition, and emotion based on principles from neuroscience and kinesiology. Structures exercise stimulate neural connectivity and promote cognitive flexibility and emotional regulation. This slide continues my presentation. Mechanism of action. Target motor challenges help development perseverance, flexible thinking, and a sense of self-efficacy. The method supports executive functions, empathy, and adaptive social emotional skills. The next slide also continues this point. Training course and pilot studies. Individualized training plans are tailored to principals' developmental need. Pilot studies show early improvements in concentration and emotional regulation after only a few weeks of training. The next slide is continuation previews slide. I will now show a short video about 1.5 minutes long with examples of brain kinetic motor exercise used with children and youth. The video presents the diversity and different levels of difficulty of the exercise from the brain kinetic catalog, which allows optimal customization of training to the specific needs of each client. Therapeutic effects. Participants showed increased self-esteem, improved interpersonal communication, and higher life satisfaction. Gains in resilience and psychological stability were maintained at 6 and 12 months follow-up. Evaluation tools. We used a standardized instrument, including the PTGI, PCL5, PTC, PTQ1RT, and ISQ. These tools helps confirm brain kinetics efficacy in self-esteem, emotional regulation, and adaptive functioning. Future perspectives. Brain kinetic is gaining recognition in Germany and in other settings, including education and child care. Ongoing research aims to standardize protocol and assessment tools to enable broader implementation on the method. On this next slide, I continue this point. Conclusions. Brain kinetic is a multidimensional adaptive approach that effectively supports post-traumatic growth by harmonizing physical activity, emotional work, and cognitive development. Its wider clinical and educational application offer promising benefits for youth mental health. This slide is also a continuation of the previous slide. Now, I would like to invite you to stand up, please, and I will you talk some simply exercise, and I kindly ask you to repeat this movements after me.
Thank you, Dr. Marzina, for your wonderful presentation. So,
I am not finished. Hello?
I'm sorry?
I am not finished.
Oh, I'm sorry.
I will show you exercise 1. Right hand to the left knee, left hand to the right knee. You can follow me when you will, is this exercise stimulates left and right hemispheres and superior, inferior, and anterior part of the brain. Exercise 2. Right hand to the left angle, left hand to the right angle. You can twirl with me, please. And this exercise stimulates left and right hemisphere and inferior, superior, and posterior part of the brain. Exercise 3. Right hand to the right, left leg to the left, left hand to the left on the side, and right leg on the left. This exercise stimulates left and right hemisphere and superior and inferior part of the brain. Exercise 4. Right hand forward, left leg forward, and left hand forward, right leg forward. On the side, this exercise stimulates right and left hemisphere and superior, inferior, and anterior part of the brain.
First of all, I would like to thank the organization of the 5th International Webinar on Neuroscience and Psychiatry for inviting me to participate in it. It is a tremendous honor for me to share the results of the research Early Behavioral and Mood Signals Associated with Tirzepatide, a comparative analysis with GLP-1 analogs. My name is Marisabel Jiménez Serranía, and I am an associate professor at the Miguel de Cervantes European University from Valladolid, Spain. As a brief introduction to myself, I'm a pharmacist, biochemist, and doctor of pharmacy from the University of Salamanca, Spain. I'm a professor of pharmacology, physiology, and biochemistry, and I do research in the field of pharmacovigilance, pharmacopidemiology, and pharmacogenetics. As a starting point, tirzepatide is a dual GLP-1 and GIP receptor agonist used for type 2 diabetes and obesity. With this rapid adoption, clinicians have begun reporting possible behavioral and mood effects. While GLP-1 analogs have known neuropsychiatry associations, tirzepatide's profile remains poorly characterized. But why this study? There is a need of early signal detection through suspected adverse drug reactions, ADR, notifications. There is a clinical relevance due to the exponential increase of use of this active ingredient in type 2 diabetes and obesity. And the GLP-1 analogs are the group with the nearest mechanism of action to tirzepatide. Given the pharmacological similarities between tirzepatide and GLP-1 analogs, we sought to determine whether tirzepatide presents a similar, broader, or distinct early behavioral and mood signal profile. Our objective was not to establish causality, but to identify early behavioral and mood ADR signals for tirzepatide compared with GLP-1 analogs and characterize unique versus shared behavioral and mood signals. Getting inside the material and methods of the research. Nowadays, free access to national and international reporting ADR databases allows investigating new signals to be aware of possible risks. One of them is BGBase, the unique World Health Organization global database for suspected ADRs maintained by the Uppsala Monitoring Center since 1968. This database disposes of a free user interface via access that allows to search for all data coming from over 110 countries under single statement of the responsibility for the appropriate use and interpretation of data. For the present study, reported data of all ADR related to the chemical subgroup A10BJ glucagon-like peptide-1 analogs and the active ingredient A10BX16 tirzepatide were searched. Data below the first heading ADRs for each active ingredient of interest, that is to say, albiglutide, dulaglutide, exenatide, liraglutide, lixisenatide, semaglutide, and tirzepatide were extracted. Signals for exenatide and lixisenatide are included and analyzed as of contrast. In this database, it is not possible to calculate the frequency of any ADR, but the data mining methodology Bayesian Confidence Propagation Neural Network (BCPNN) can be used in these situations. Nevertheless, this methodology is developed and used by the UMC at the World Collaborating Center for International Drug Monitoring. To detect signals of ADR, this method, BCPNN, are input by UMC with an extension to the multiple comparison settings. The calculated Bayesian estimator of false discovery rate, FDR, works like a p-value offering a positive signal if FDR is less than 0.05. An adaptation of this methodology can be plausible, as same as other diverse methods can be trustworthy in both adverse drug reaction surveillance with a correct interpretation of the signals. This one consists of contrasting all the ADR of the ATC subgroups instead of all pairs ADRs drugs of the database. In this case, the chemical subgroup is A10BJ glucagon-like peptide analogs and the active ingredient A10BX16 tirzepatide considered into analysis. This methodology approach applied was previously demonstrated robustness and consistency when instead of all ADR databases were applied to a specific subgroup of drugs such as anticoagulants, antidiabetics, COVID vaccines, or statins. You can see here details of the algorithm performed, but in essence the estimator of FDR less than 0.05 and specificity greater than or equal to 0.99 are considered to interpret the results. Let's go to the results. The total of positive signals with tirzepatide was 264, being 24 out of them related to behavioral and mood disorders, and as you can see, the highest value belongs to anxiety with more than 25% of the signals. The first set analyzed was unique tirzepatide signals. All of signals were not stated in summary plot characteristics. These signals were statistically significant for tirzepatide and not observed for GLP-1 analogs within the dataset. They suggest that tirzepatide may have unique neuropsychiatric interactions beyond GLP-1 receptor modulation. In our disproportionality analysis, acute psychosis, anhedonia, anorexia nervosa, mania, obsessive-compulsive disorders, panic attack, and terminal insomnia emerged as early psychiatric signals uniquely associated with tirzepatide and were not detected for other incretins-based agents in the same dataset. This is consistent with emerging post-marketing evidence suggesting that tirzepatide may have a distinct neuropsychiatric safety profile, with case reports and pharmacovigilance studies already describing heterogeneous psychiatric adverse events in real-world users, including anxiety, mood changes, and complex behavioral symptoms. Although recent systematic reviews for tirzepatide clinical trials do not show a major excess of neuropsychiatric adverse events overall, they emphasize that spontaneous reports and case series remain essential to identify rare or unexpected reactions that are unlikely to be captured in pre-approval trials, supporting the interpretation of these findings as unique early signals that warrant further investigation rather than established causal effects. The fact that these psychiatric events appear only with tirzepatide in our signal detection analysis is biologically plausible given its dual GAP-GLP-1 receptor agonism and the dense expression of incretin receptors in brain regions that regulate mood, reward processing, stress reactivity, and sleep-wake cycles, prefrontal cortex, amygdala, hypothalamus, and brainstem nuclei. Contemporary neuropsychopharmacology reviews shows that GLP-1 receptor agonists modulate dopaminergic and serotonergic transmission, glutaminergic signaling, and neuroinflammatory pathways, all of which are implicated in psychosis, mania, obsessive-compulsive symptoms, panic, and insomnia. Recent psychiatric and endocrinology literature also highlights that incretin-based therapies, including dual GAP-GLP-1 agonists such as tirzepatide, may exert both beneficial and adverse mental health effects, reinforcing the need for systematic monitoring of new drug-specific psychiatric signals like those identified here. The second set analyzed was tirzepatide's signals shared with semaglutide. Tirzepatide showed significant overlap with semaglutide. Many of these relate to sleep regulation, appetite, mood, and cognition. This overlap likely reflects the GLP-1 component of tirzepatide's mechanism. It especially highlighted the intrusive thoughts, the sleep deficit, and the sleep terror with a sensitivity more than 0.20. The higher sensitivity values observed for intrusive thoughts and sleep deficit in tirzepatide compared with semaglutide are consistent with a distinct neurobiological profile of the dual GAP-GLP-1 receptor agonism. Experimental studies show that both GLP-1 and GAP receptors are expressed in brain regions responsible for cognitive control, sleep monitoring, and sleep-wake homeostasis, including the prefrontal cortex, amygdala, and hypothalamic nuclei. GLP-1 signaling modulates serotonergic and dopaminergic circuits, which are directly involved in ruminative and intrusive thinking patterns, while also influencing autonomical arousal and sleep depth. Recent neuropsychopharmacology reviews demonstrate that incretin agonism can alter attention, emotional silence, sleep architecture, and cognitive emotional integration, providing a plausible mechanism basis for tirzepatide showing a stronger early signal than semaglutide in these domains. The finding that sleep terror shows a sensitivity more than 0.20 for both tirzepatide and semaglutide aligns with evidence that GLP-1 receptor agonists influence REM and NREM transitions, autonomic arousal, and limbic reactivity during sleep. GLP-1 signaling affects hypothalamic sleep centers and interacts with stress regulation pathways, which may precipitate parasomnias such as night terrors in susceptible individuals. Pharmacovigilance studies of GLP-1 analogs have already identified abnormal dreams, parasomnias, and nocturnal arousal phenomena as recurrent sleep-related adverse events. Because parasomnias typically arise from dysregulation of sleep and REM sleep combined with heightened autonomic activation, the shared signal across both drugs likely reflect a class-related incretin effect, while the magnitude may differ by molecule-specific CNS penetration. Next, compared with dulaglutide, tirzepatide showed fewer overlapping psychiatric signals. This suggests potential mechanistic or population differences influencing reporting patterns. The higher sensitivity values observed for both sleep disorders due to a general medication condition and its insomnia subtype in tirzepatide compared with dulaglutide are consistent with the distinct central pharmacodynamic profile of tirzepatide. Unlike dulaglutide, tirzepatide acts as a dual GAP-GLP-1 receptor agonist, and increasing evidence indicates that GAP receptors are expressed in hypothalamic and brainstem region involved in sleep regulation, autonomic tone, and stress responsiveness. Dual agonism have been shown to produce broader CNS engagement, including modulation of arousal pathways, circadian rhythm centers, and neuroinflammatory mediators that can influence sleep continuity and nocturnal awakenings. This mechanism provides biological plausibility for tirzepatide presenting more prominent early sleep-related signals than dulaglutide in pharmacovigilance datasets. Also, the low sensibility of dulaglutide for both categories of sleep disorders aligns with pharmacological reviews, indicating that dulaglutide has limited central nervous system penetration compared with other incretin agonists. Dulaglutide's larger molecular size and reduced capacity to cross the blood-brain barrier results in more restricted direct activity on sleep-wake circuitry, particularly if hypothalamic mechanism governing insomnia, circadian rhythm stability, and autonomic activation during nighttime. Reviews comparing GLP-1 receptor agonists confirm that dulaglutide exhibits weaker central effects relative to smaller, more lipophilic molecules. For this reason, sleep-related adverse events appear less frequently and with lower sensitivity with dulaglutide pharmacovigilance data, in contrast with tirzepatide, whose dual mechanism appear to produce a broader neurobehavioral signal profile. In a final step, we analyze cross-drug findings shared across tirzepatide, semaglutide, dulaglutide, and liraglutide. Food craving regulation and suicidal ideation may represent class-wide neuropsychiatric signals among incretin-based therapies. This warrants further study, particularly in high risk. In detail, the elevated sensitivity values for anxiety, feeding disorders, and food craving in tirzepatide are consistent with its dual GAP-GLP-1 receptor agonism, which produce broader central effects than GLP-1 only agents. Both GLP-1 and GAP receptors are expressed in hypothalamic, limbic, and mesolimbic circuits that regulate appetite, reward anticipation, stress responses, and emotional salience. Experimental and clinical research shows that incretin signaling modulates dopaminergic and serotonergic pathways involved in anxiety and reward-driven eating, while also altering hypothalamic centers that could control hunger, satiety, and compulsive food-shaking behaviors. These mechanisms provide biological plausibility for tirzepatide displaying stronger early behavioral signals in real-world pharmacovigilance data, particularly in domains such as anxiety and dysregulated feeding behavior. In addition, although tirzepatide clinical trials have not demonstrated an excess risk of suicidal ideation, real-world pharmacovigilance analysis of GLP-1-based therapies show that mood alteration and suicidal thoughts can emerge in a subset of patients across incretin agonists. GLP-1 receptor activation influences serotonergic tones, stress reactivity, and limbic system dynamics, while dual GAP-GLP-1 agonists exert broader neuromodulatory effects that may further amplify vulnerability in individuals predisposed to mood disorders. Recent analyses from global safety databases highlight that psychiatric adverse events, including depressed mood and suicidal ideation, are among the most frequently reported neuropsychiatric events for GLP-1 receptor agonists. Thus, the signal detected for tirzepatide should be interpreted as an early warning indicator that warrants monitoring rather than proof of causality consistent with WOW guidance for emerging ADR signals evaluation. Due to all, clinicians should closely monitor patients with pre-existing mood disorders, sleep disorders, or eating disorders. These findings underline that real-world pharmacovigilance is crucial as use expands. Limitations of this study is that spontaneous reports inherently include underreporting, stimulated reporting, and missing data. However, they remain one of the best tools for early pharmacovigilance. Conclusions of this study are: 1. Tirzepatide shows unique early psychiatric signals. 2. Overlap with semaglutide suggests GLP-1 related effects. And 3. The importance of further clinical research. These conclusions underscore the need for vigilance monitoring and focused research to determine whether tirzepatide's broader psychiatric signal profile reflects true drug-specific effects or emerging real-world patterns. Future work should integrate mechanistic neurobiological studies with prospective clinical research to clarify the origins, relevance, and patient-level determinants of these early psychiatric signals, ultimately supporting safer and more personalized use of tirzepatide. I hope that these results presented will be useful to have safer treatments and provide a starting point for future studies in behavioral and mood signals conditions with tirzepatide. I am at your disposal for any questions you may have about this work. Thank you very much for your attention.
I'm presenting myself. I am Irina Katsmazilou, living in Paris, France, and I am an art therapist, a trainer, a supervisor in night therapy, and as well a visual artist, active visual artist. So in this presentation, I would like to share with you an article written and published in this book. So the book is called The Theory and Practice of Group Therapy. And the article, the title of the article is A Case of Music and Choral Painting in Online Art Therapies. So it was a very interesting case and a successful art therapy. I just explained the context in a few words. So it was in the time of the COVID pandemic and in the lockdown time. So it was very difficult for everybody. And as I am a full member of the European Federation of Art Therapy, I participated in action that we did implement. We offered to anyone, everywhere, needing online art therapy, 8 free sessions from full members of the IFAT. And so I had maybe 10 clients who got in touch with me. And this case is about a 19 years old young woman from Italy. So she was in Italy, I was in Paris, and we worked online. And I have to say it was the first time in my life that I did art therapy online because everybody was at home, locked in. And I did not have the opportunity before these times to make online art therapy. So it was a very challenging experience. So the 8 sessions online went to their end, and then the young woman came the year after that in Paris to visit Paris, and she came for a session to me. So after this work online, we once meet in presence, and it was very, very nice and important. So the young woman, whose name is Margherita, she accepted to publish under her true name, and I had her consentment for images and videos that I can show you rapidly. And so she was a student in first year at the university, but because of the lockdown, she had to go back to live with her mother, which was difficult for her. Her mother was not well because the father left the home 1 year before to live with another person. And coming back home for Margarita was difficult. She could not see her friends except online, of course, as all of us. She was depressed, she was afraid, and she also had anorexia problem starting before the COVID time. So it was a rather complicated picture. And Margarita is a high potential person, very gifted for painting, gifting for music, for dance, for writing. So I titled this article a choral painting and music case, even if we were just the two of us. But we used painting, music, writing, photos, talking, of course. So it was like a polyphonic work. And I asked her in the beginning about what she would like to do. So she said, I would like to paint, but in music. So she put her own choice of music each time and painted very freely. So at some moment, this is very important, she used her hands for painting. I suppose you can see the photos. And at this moment, maybe at the middle point of her art therapy, I propose her to paint with food. Use eggs, use coffee, use tomatoes, and her hands, so that the creative act was very sensual and very embodied. So she also used to paint between the sessions and send me images and poems she wrote. And of course, I responded. So we got in contact all the time. And here you can see the end of the process. Oh. The end of a process. It is her explaining. And we made a choral painting. You can see here. It means that she put a music, she painted in her home, and I was painting at the same time in my studio. And then we shared about this. It was a very, very powerful relationship, creative relationship. And then she sent me a drawing of herself as she was before the therapy sessions, and here she is at the end. And what is interesting is that she went out of her anorexia and she told me, now I love my body and it is okay. So later she went to study theater. She came to Paris, to Sorbonne, for 1 year of theater drama studies, and now she is back in Italy. And even if the art therapy was very short, only 8 sessions, it was very powerful and successful, and I was happy for her. So I would like to show you, just to share with you a short piece of video that this will make you feel better what we did than explanations. So I hope it will. Okay, so this is it, and maybe you could feel how she was embodied in her painting with music and embodied in her body. So now, just to finish, I will share a slide with the references of the, where is it? No, once again, thank you for listening to me. And if you want to have more information, more images, more analyzing, so can you see the references? Can you see the references of the IFAD? Yes, the link to the article, which is in open access. The book is in open access. And here you have my email and my site. But anyway, if you want to have some more explanations and some more, how should I say, more deep insight in this case, you can read the article online. Okay, thank you for listening.
Ladies and gentlemen, dear fellow doctors, esteemed medical community, and esteemed scientific and organizational committee of the great international conference in which I have the honor to participate with my present speech. I sincerely thank you for today's proposal to present the recent research results of a large medical study of which I am the head and which is taking place at the Medical School of the University of Crete in Greece and in the public health system. Our medical research has been approved by the Board of Directors and the Scientific Council of the General Hospital of St. Nicholas, of the National Health System of Greece, by the 7 Health Region and the Ministry of Public Order and Citizen Protection of Greece, based on Article 87 of Law 4812/2021. The first results of our research were published on August 8 in 2025 in the International Journal Frontiers of Psychiatry in the field of psychopharmacology and concerned a sample of 55 patients with comorbidity of neurodevelopmental disease and substance use disorders. The sample is divided into two groups: patients who were monitored in the hospital on a regular basis and patients who were examined within the correctional institutions in which they were held. Today, our research has evolved further and the patient sample has almost doubled, reaching a total of 98 patients. This final sample will be the focus of this presentation. We decided to examine the administration of injectable antipsychotic treatment, referred to as DPO, in patients with psychotic comorbidity in the context of neurodevelopmental disease and substance use disorders. The dominant reason for administering injectable treatment was the imperative need to integrate patients into a well-defined and adapted to the hardcore of the illness therapeutic treatment framework. The research data which we had in mind at the beginning of our research was the injectable long-acting antipsychotic treatment brings about patient compliance with their treatment, especially in incarcerated patients who presented greater indiscipline. Non-compliance with medication by patients increases the risk of relapse, hospitalization rates, treatment costs, and the likelihood of involvement with the law, leading to a vicious cycle of revolving door hospitalization in the general hospital and imprisonment in the penitentiary system. Our study evaluates the benefits of administering long-acting injectable aripiprazole to the patients in our sample. Aripiprazole monohydrate as a third-generation antipsychotic medication that acts as a partial D2 agonist, bringing about the necessary balance between treating the positive symptoms of psychosis and maintaining adequate cognitive function. It actually seems to have mainly partial agonist activity at presynaptic D2 receptors and antagonist activity at postsynaptic D2 receptors. The drug's mechanism of action inhibits the hyperactivity of the dopaminergic system in the mesolimbic system, while at the same time enhancing the reduced activity of the dopaminergic system in the prefrontal cortex. It enhances the activation of the dopaminergic system in the dorsolateral prefrontal cortex, with proven improvement in working memory, while at the same time we support the increase in dopamine activity in the ventromedial prefrontal cortex, resulting in improved emotional expression. As a 5-HT1A agonist and 5-HT2A antagonist, aripiprazole functions as a stabilizer of the dopamine-serotonin system. It appears to modulate the in vivo release of serotonin and dopamine in the medial prefrontal cortex through appropriate activation of serotonin via 5-HT1A receptors. These serotonin receptors, which are abundantly expressed by pyramidal neurons, mediate changes in cortical dopaminergic transmission induced by atypical antipsychotic drugs, playing an important role in normal and pathological prefrontal cortex function. Activation of 5-HT1A receptors appears to hyperpolarize prefrontal neurons in vitro by increasing potassium conductance, which reduces firing rate. In addition, aripiprazole acts on GABA transmission. Postmortem studies have reported upregulation of GABA receptor binding in the prefrontal cortex of patients with schizophrenia, suggesting reduced prefrontal GABA transmission. Studies have shown that GABA-A receptor binding potential are significantly lower during aripiprazole administration in the right ventromedial prefrontal cortex, left mesofrontal cortex, and right dorsolateral cortex, suggesting increased prefrontal GABA transmission due to aripiprazole. The ventromedial cortex is specialized for social cognition. The mesofrontal cortex functions as a regulator of social cognition by passing current processing to explore novel options, whereas the dorsolateral cortex is thought to contribute to cognitive control in social situations. However, the exact relationship between aripiprazole and GABA has not yet been studied. Atypical antipsychotics, such as aripiprazole, are also used to treat treatment-resistant depression, as well as post-traumatic stress disorder. Oxidative stress contributes to the stimulation of pro-inflammatory cytokine production. Recent studies have suggested that elevated levels of cytokines are involved in the molecular mechanisms of depression. It has been found that increased serum pro-inflammatory cytokines, such as interleukin-6, can cause a decrease in brain neurotrophins, such as BDNF, as cytokines cross the blood-brain barrier. Low levels of BDNF and other neurotrophins appear to play an important role in the expression of serious mood disorders, including depression. Aripiprazole has been shown to have a positive effect on restoring levels of the neurotrophins BDNF and GAP43 in the hippocampus and prefrontal cortex. Dysfunctional calcium signaling mechanisms are also involved in the pathophysiology of depression. There is some evidence of overexpression of the CAGNA1C gene, which is involved in encoding calcium channels after chronic stress in brain regions involved in emotional and stress responses. Based on data indicated the effect of aripiprazole on intracellular calcium levels, a study in the stress-induced depression model in rats showed that the antidepressant effects of aripiprazole are due in part to inhibition of CAGNA1C overexpression. Our study included 98 patients, 68 of whom were from the communities and 30 were held in a prison in southeastern Greece. The World Health Organization Quality of Life Scale and the Clinical Global Impression Severity Scale were used respectively to assess the quality of life and the functioning of the patients after the start of treatment. The number of hospitalizations of the patients were also 24 of them had a diagnosis of schizophrenia, only 5 had a traumatic brain injury, 56 of them had an anxious cluster C personality type, while 40.9% were taking at least one psychotropic substance and or alcohol. The mean age of the sample was 40.66 plus minus 13.91 years. Regarding the 30 patients who were incarcerated, all were male, all had a diagnosis of atypical psychosis, except for one who had a diagnosis of schizophrenia. No one had a traumatic brain injury. 14 of them, about 46.67%, had a cluster C personality type, while 53.33% had a dramatic cluster B personality type. All of them were taking at least one psychotropic substance and or alcohol. The mean age of the sample was 38.73 plus minus 8.75 years. The two patient samples differed statistically significantly in almost all demographic personal data and their medical history, except for the presence of traumatic brain injury and the parameter of mental retardation or reduction. Patients in the correctional facility had a statistically significantly lower number of hospitalizations, a better general clinical picture, and a better quality of life than patients in the community. Regarding the number of hospitalizations, in the community patients, these were reduced statistically significantly from 1.01 before depot treatment to 0.01 after depot therapy. The range of each value is listed in the tables. Regarding the imprisoned patients, hospitalizations decreased from 0.77 before depot treatment to 0.0 after depot therapy, which means that this decreased absolutely. This decrease is considered statistically significant as the paired samples Wilcoxon sign-rank test gives p-value equal 0.0066 less than 0.05. Based on our clinical observation, we have observed that after the third monthly administration of injectable aripiprazole, the patient's clinical picture tends to show a distinct improvement with a clear tendency towards stabilization over the period of 4 to 6 months. Therefore, we decided to analyze our data, taking into account two key time points, 3 and 6 months. In terms of functionality, the 3-month administration of long-acting injectable antipsychotics demonstrated the following. In the community patients, the score on the Clinical Global Impression Severity Scale decreased statistically significantly from 5.72 before depot treatment to 2.34 3 months after depot treatment. This result means that the improvement of the patient's overall clinical picture responds to a modification from severely ill to moderately ill. Regarding the patients who were incarcerated, the score on the same scale showed a statistically significant decrease from 5.4 before depot treatment to 2.37 3 months after depot treatment. This result means that the improvement in these patients corresponds to a change from significantly ill to mildly ill. In terms of functionality, the 6-month administration of depot demonstrated the following. In the community patients, the CGI-S score decreased statistically significantly from 5.72 before depot treatment to 2.946 months after depot therapy. This result means that the improvement of the patient's overall clinical picture corresponds to a modification from severely ill to moderately ill. Regarding the incarcerated patients, the CGI-S score decreased statistically significantly from 5.4 before depot therapy to 2.17 6 months after depot. This result means that the improvement of the patient's overall clinical picture corresponds to a modification from significantly ill to slightly ill. As regards the assessment of the quality of life of the sample of patients, 3 months after the administration of long-acting injectable antipsychotics, we observed that in the 68 patients in the community, the score of the quality of life scale increased statistically significantly from 0.57 before depot treatment to 2.3 3 months after depot therapy. This result means that the improvement in these patients corresponds to a modification from very bad to good. As regards the 30 patients who were incarcerated, the quality of life scale score also increased statistically significantly from 0.7 before depot treatment to 2.36 3 months after depot treatment. The patient's overall clinical picture was modified from bad to good. Regarding the assessment of the quality of life of the sample of patients 6 months after the administration of depot, we observed that in the community patients, the score of the quality of life scale increased statistically significantly from 0.57 before starting treatment to 3.35 6 months after starting depot treatment. This result means that the improvement in these patients corresponds to a change from very bad to good. As regards the imprisoned patients, the quality of life scale score also increased statistically significantly from 0.7 before treatment to 3.6 3 months after depot treatment. The patient's overall clinical picture was modified from bad to good. Our study is the first in Greece to evaluate long-acting injectable aripiprazole in community patients with psychotic symptoms and behavioral disorders due to chronic alcohol or substance use and dependence. Also, is the first study in Europe for incarcerated patients with unspecified psychotic symptoms and behavioral disorders induced by substance use disorders. Aripiprazole, as a partial agonist of D2 and 5-HT1A receptors and enhancer of GABA transmission, increases dopamine function, serotonergic function, and GABA action in the prefrontal lobe, improving working memory, emotional response to stress, and social skills of patients. Furthermore, long-acting injectable antipsychotics improve patient compliance with treatment, leading to enhanced long-term effects in improving the patient's clinical picture. It is indicated for the prevention of relapses in schizophrenia, manic episodes in bipolar I disorder, as well as irritability in autism, while it is a promising treatment of choice for behavioral disorders due to chronic use and dependence on alcohol or cannabis. Our study of 68 community-based and 30 prison-based patients revealed significant demographic and medical history differences. Both groups of patients experienced reduced hospital admissions and improved functional and quality of life scores after long-acting injectable administration. Patients in the community showed a greater reduction in hospital admissions, while improvements in functionality and quality of life were comparable between the groups. Our study supports the strategy of expanding mental health services to the community, including crisis intervention programs and early intervention for psychosis, as well as the strategy of coordinating the correctional system and the National Health Service. It is important to note that a study in Germany, published in 2018, examined the factors influencing the cost of schizophrenia for patients before and after switching from oral antipsychotic treatment to depot treatment. A budget impact analysis was performed referring to the German healthcare framework. It was observed that treatment with depot aripiprazole significantly reduced the average number of hospitalizations per patient and the average number of hospital days. As shown in the table, the indicative cost of treating a patient with oral antipsychotics is set at approximately €9,935, while treatment with depot aripiprazole resulted in a cost of €4,557 per patient over a one-year observation period. These results are indicative of the large cost savings that depot treatment offers to a health system. Concluding my speech, I would like to mention that at the Medical School of the University of Crete, we operate Center of Genetic Medicine and Forensic Psychiatry with a special department of alcoholic patients in which we promote research and practice clinical medical work on a large number of patients. Thank you especially for your attention.
Good morning. We live in a virtual game, the Vignetti model. This title is the conclusion of about 20 years of work in cognitive sciences and philosophy of mind. The Vignetti model was the cognitive model elaborated during this time. Now, let's see which are the fundamental premises that led us to this model. Our intelligence self-deludes into perceiving the outer world A and the inner world B as real. A. What about the outer world? Our sensory organs give us limited, imprecise, and somehow artifactual information of the world around us. So we perceive a world that is not real, but imaginary and somehow fake. However, we do not realize that. Optical illusions can mislead our intelligence. Arcimboldo, Dalí, Escher, and many other artists were inspired by optical illusions. A classic psychophysical example is the Fraser spiral, which is not a spiral but a series of concentric circles, as you can see on the right. Other examples of misleading perceptions of the world come from the olfactory, the acoustic, and the gustatory senses. The auditory cortex perceives a very limited range of frequencies. Moreover, the olfaction can perceive only volatile molecules of molecular weight below 300. The bell pepper odorant is one of the strongest smells, together with the geosmin, the wet ground odorant. Again, the gustatory sense must interact only with some hydrophilic molecules. An example is releasing monosodium glutamate from proteins due to ripening that transforms fresh pork thighs and milk into raw Parma ham and Parmigiano Reggiano cheese, respectively. As it regards colors, our mother taught us what is red, but the quality of the reddiness is a quail. Philosophers of mind introduced this term to specify a peculiar quality of a stimulus whose definition is subjectively known, but objectively impossible to share with others. Moreover, 3 kinds of photoreceptors in the retina intercept only 3 colors, but the nature does not emit colors. It emits electromagnetic signals. Moreover, we perceive only a tiny portion of all the electromagnetic spectrum. Our brain can see only supramolecular and supracellular events. The brain can see the matter with dimensions not less than 10 microns and can work with a speed far less than light speed. Thus, it is subordinate to the classical physical domain. In other words, we lose a huge amount of information of the world, the black matter. What about the inner world, B? We strongly believe in free will existence, though many evidences demonstrate that free will is an illusion of the mind. Next slide. Here is a list of evidence that deny free will existence. Some are based on pure logic. For instance, the first item, if free will should underlie our actions, the world would be a mess. Others are based on experimental evidences. The last 3 items, 1, 2, and 3 in red, will deserve a few minutes of deeper analysis. The first item in red, the probabilistic deterministic mechanism of adaptive systems, the analogy between physical chemical systems and the brain. At left, throwing only once the dice or trying the determination of the sex in a fertilized egg is a pure chance event. At the right, the Galton's machine explained that a single ball falling down a chute with many skittles bounces at left or at right in a stochastic way, so it ends the run at a position totally unpredictable. Again, this single action is a pure chance event, like the dice and the determination of sex in fertilized eggs. Conversely, many balls falling down altogether distribute down according to a normal equation. This main behavior can be mathematically predicted. This is not a chance behavior, rather it is a deterministic one. Another classic example is the behavior of gas molecules. Each single molecule moves at random, but the collection of molecules as a mean respects the gas law's prediction. For instance, if you increase pressure, the volume will decrease proportionally, etc. Brain is made of billions of elements, molecules and cells that singly behave at random, yet their functional assemblies move in a deterministic way, in analogy with the Galton's machine. The computational mechanism of the brain is statistically based on large number of events. Just one example for all: the action potential transmission along a neural membrane and the voltage-sensitive sodium channel. A huge amount of voltage-sensitive sodium channels are located on the neuronal membrane and control sodium entries, then playing a crucial role in action potential movement. The action potential shape is on the left, and the behavior of a handful of sodium channels are on the right. With the patch clamp, an electrophysiological technique, we can monitor the responses of a handful of channels of a tiny patch of neuronal membrane. When an action potential is passing through, action potential depolarizes the membrane from -80 to -40. As you see, the channels singly open and closes at random. However, their mean response, the one below, is unique and deterministic. It is the response that is expected when the action potential passes through. Second point, red. Learn and memory are predictable processes, thus they are incompatible with the presence of a free will possessing ego or soul, guiding the mind. Cognitive processes in the absence of free will. This is an example of learning curves obtained in different experimental conditions, the different colors. The red experiment, for instance, refers to the experiment in which an object must be recognized by the subject as fast as possible on a computer screen. The probability of recognition is reported on the y-axis in function of trials on the x-axis. At the beginning, the probability is very low. Then it becomes maximal on top of the hyperbolic curve, when the stimulus has been fully memorized and its recognition becomes instinctive. It is automatic. According to Bayes, the prior probability primes the posterior probability. You see the equation on the right. So the learning process is going from purely probabilistic to fully deterministic. The third item in red, Libet's experiments show that a readiness potential anticipates a few milliseconds the awareness in a so-called voluntary action. Libet's and the readiness potential taken from mind's timing of a voluntary action, conscious or unconscious. Assume a policeman suddenly appears and you must stop your bike because you are accustomed to brake the bike. In 200, 300 milliseconds you can really stop, but you are not yet aware of this unconscious action. Now, to become aware of the policeman, it will take 400, 500 milliseconds. Actually, your unconscious mind will instinctively stop the bike according to an automatism already registered in your mind. Only after 200, 300 milliseconds more, you will become aware of it. In conclusion, the unconscious action always anticipates the awareness of it. So, the paradox, our intelligence cannot be guided by a free will possessing agent, though it exhibits resilient and adaptive strategies. How is it possible? The Vignetti model can solve this paradox. Our virtual intelligence emerges from the brain as a physiological dual state of the mind. This is a very old known evidence. The unconscious or implicit mind uses a biophysical, biochemical language on the left. Instead, the conscious or explicit mind thinks, speaks, plays music, counts, etc. on the right. The two functional domains coexist and exchange information by self-translating their languages in a mysterious way. Unconscious mind elaborates the reaction against a perturbing stimulus. Since this information takes time to be translated in conscious mind's language, the awareness in conscious mind rises hundreds of milliseconds later than the real action. Therefore, conscious mind is in the dark of the action decision mechanism that unconscious mind has carried out. That's why conscious mind believes to have freely decided that action in the place of unconscious mind. This is the rise of the free will illusion. So, conscious mind feels confident to upload the experience to long-term memory, to upload the successful experience, of course. Let's make an example. If the stimulus is new, you know, the theory of the tabula rasa when we are very young, unconscious mind will react by using random paradigms according to a trial and error strategy. Probabilistic processes C1 and 2. The trial after trial, the unconscious mind will find the reaction quenching thirst, thus stopping stimulation. By observing the outcomes of the reactions, conscious mind discovers and memorizes the correct paradigm in point 3. In long-term memory, in the future, unconscious mind will proceed directly to point 3 in long-term memory without a further need of conscious mind's intervention. The more long-term memory will be updated, the more UM's reaction will become automatic and maximally efficient, deterministic process. We are now on top of the learning curve. Concluding, we arrive to explain the title of our talk. We live in a virtual game. We have seen that the kind of world we perceive is virtual, and that our intelligence conforms the cognitive processes to this context. To do so, our intelligence emerges from the brain as a computational unit made of CM and UM together. CM and UM play the same role respectively as the player with the Oculus Rift and the joystick and the avatar on the screen in a virtual game. The avatar reacts to a stimulus, obeying to a paradigm already memorized in the past. The feedback signals of these reactions reach the player. It has the conscious mind. Later on, then the player becomes aware of the outcomes of the reactions with delay, thus believing to be responsible of them, a free will illusion. According to the reward or the blame, the player self-attributes for the reaction outcomes. He can update the paradigm in the memory archives for future avatars' actions. By this reinforcement learning, our virtual intelligence learns and memorizes from the reaction experience of the present time how to move better and better in the future, even if in the absence of free will. In summary, we live in a virtual game, yet our intelligence carries out resilient and successful cognitive processes. The Vignetti model explains this paradox by claiming that our intelligence has genetically and epigenetically evolved towards a physiological dual state of the mind, enabling us to live as if we were in a virtual game. Autopoiesis and artificial intelligence. According to Maturana and Varela, simple biological systems are autopoietic. It is they can self-organize and self-reproduce by means of innate, recursive metabolic processes. As far as it regards humans, they are more complex systems since their life depends also on psychological mechanisms. Actually, they live like in a virtual game, yet their virtual intelligence, VI, carries out resilient and successful cognitive processes. As seen above, the Vignetti model can explain this paradox by introducing the physiological dual state of the mind that carries out a series of recursive cognitive loops similar to the reinforcement learning. Based on this evidence, we can conclude that UM and CM strictly cooperate in cognition, since their activity stands on a probabilistic deterministic mechanism that exhibit recursive processes. At first, we can definitely deny the presence of a free will possessing ego, guiding our mind. Secondly, we can conclude that this kind of psychic behavior typically reveals an autopoietic nature. TBM claims that our virtual intelligence, VI, is imprecise and limited, though it is resilient to the stresses of the environment and is genetically equipped to self-adapt to a virtual life. To this aim, UM, unconscious mind, and CM, conscious mind, coexist and strictly cooperate for cognition with complementary roles. Erroneously, we identify our intelligence only with CM, since it may carry out thinking, dreaming, creating music, and making science, and is overly presumed to us of being self-conscious. Nevertheless, CM cannot objectively define UN, being the other side of the same coin. Then it cannot scientifically define what is consciousness as a whole, for an evident conflict of interest. As a maximum, CM can investigate on the neural correlates to consciousness, but this is not enough to say that it may create an analogous form of intelligence. CM has not the system authority to clone the whole virtual intelligence into artificial intelligence. AI might be a fantastic computational system in the hands of VI, though lacking of a fundamental property of our VI. The cooperative work between UM and CM, by means of which our VI can collect the necessary data to solve problems with an autopoietic.
Good morning for us, good afternoon for you. So the paper that Dr. Alexander and I published is not a case study, though one case is featured prominently, Andrew. This article is also not advocacy for one approach to treatment, though one approach is featured predominantly, which is probiotics. Rather, this article is a reconsideration about how we practitioners go about delivering treatment to youngsters with autism spectrum disorder, ASD. The focus here is on order of services to boost efficacy.
Our paper suggests that one of several biological modifications either precede or be concurrent with an environmental modification for maximum synergistic impact. Recent research is targeting individuals on the autism spectrum, ages 1.5 to 20, an expansion in age in both directions over the past several decades. Potential biological approaches center upon probiotics, diet or vitamin mineral supplements, microbiota transfer therapy, MTT, aka fecal transfer therapy, or homeopathy, while current environmental options focus upon applied behavior analysis, often called ABA, pivotal response training, PRT, sensory motor integration, or exercise programs.
Definitions. Probiotics is the ingestion of live healthful bacteria. A proposed mechanism of action is the recolonization of the intestinal membrane by healthy bacterium adhering to human mucosal cells. Displace harmful bacteria with establishing new friendly bacterial communities. Microbiota transfer therapy is a medical procedure that involves transforming stool from a healthy donor to a patient's gastrointestinal tract. The aim is to restore the balance of gut bacteria, often disrupted by severe GI conditions. Homeopathy refers to the treatment of disease by minute doses of natural substances that in a healthy person would produce similar symptoms of that disease.
Applied behavior analysis, ABA, aims to teach specific functional skills, reduce problem behaviors, and improve language and intellectual functioning through a personalized, step-by-step teaching curriculum implemented by parents and therapists. Pivotal response training, PRT, begins with child choice and uses intrinsic reinforcement to foster child motivation, initiative, and generalization of social communication. Emphasis is on a set of teaching practices rather than specific teaching content. Sensory motor integration refers to the brain's ability to receive, process, and organize sensory information from the body and environment, and then respond with appropriate motor actions. When I was a graduate student in the 1970s, The window of opportunity for change in youngsters with autism closed at age 6 years of age. Somewhat later, the age was raised to 9. But at least until now, 11 years of age has remained outside of that window, especially for children with early onset autism. This disorder is characterized by little or no eye contact and no inclination toward bonding with mother, siblings, or friends, often in conjunction with little or no verbalization and high rates of repetitive motor patterns of self-stimulation and tantrums. Such treatment-resistant non-responders were no doubt part of the 53% of the unsuccessful treatment group in the landmark Young Autism Project, headed by doctors Ivar Lovaas at UCLA, 1987, Laura Schreibman at the Claremont Colleges, and Robert Cagle at UC Santa Barbara. In spite of his giant step forward, the failure of the majority weighed on Dr. Lovaas like an anchor in our personal communication, and he hoped that a biological, organic course correction might be realized someday through nutrition, pharmacy, or surgery. Andrew, a fictitious name, fit the initial diagnosis and ongoing profile of early onset autism when Dr. Frank introduced homeopathic treatment at my request. Andrew, then age 11, was in a special education class with more than 2 years of ABA provided by a skilled, experienced therapist. Andrew had made no discernible clinical progress at home or at school. I could not elicit eye contact even with the inducement of chicken nuggets, the almost exclusive staple of his diet. Yet after several months of homeopathy, Andrew began to sit in large groups of students at school, cope with stimulation around him, and produce first sounds and then words. Hi, bye, again, go now. Pointing and nodding facilitated communication. Last year, Andrew, now a teenager, had a blast at a school prom with all of the attendant loud noises and crowding. Smiling broadly, he was photographed with a lady on his arm and developed a reputation for flirting at school. Andrew, now 19, continues to make strides reported monthly by his parents. What went right? A right possibility for reverse engineering, awaiting additional empirical support.
A biological setting event for environmental modification. We believe that homeopathic remedies began to alter a severely compromised dysbiotic gut microbiome, ousting pathogens and producing a more improved balance between healthy and harmful bacteria. This in turn would be expected to benefit the critical gut-brain connection largely responsible for cognition and behavior, a systemic boost. The homeopathic regimen included various times hyperdiluted safe dosages of calcium carbonate, Sina, and coffea cruda. We also added alfalfa, cod liver oil, and probiotics to stimulate a healthy flora, heal the gut, and also improve metabolism of minerals. Not only did we observe improvement in all behavioral indicators for Andrew, but also on organic sensory-based patterns such as shampoo and bar soap pica, now long gone, and a marked expansion of dietary choices associated with the calc carb and dietary supplements. Retrospectively, we speculate that there were other Andrews in that 53% of young autism project non-responders who lacked such a biological setting event, even with 40 hours weekly of behavioral services. Homeopathy is by no means intended to be exclusive as biological modification, but rather one possible course correction that unlocks the door for ensuing environmental stimulation such as special education, changes in diet, vitamin, mineral supplementation, fecal microbiome therapy, though still somewhat controversial, may also set the occasion for the changes we observed. At this juncture, we throw our initial support to more standardized intervention through probiotics, since a homeopathic approach is very difficult to manualize. More on that later.
Probiotics, the ingestion of live, healthy bacteria, can be built around safe, well-researched, robust probiotics such as Lactobacillus acidophilus and Bifidobacterium bifidum lactis. Beta-glucans can provide enhanced probiotic supplementation for dangerous persistent infections such as Clostridium difficile, C. diff. A thorough GI workup can guide which strains of lactobacillus or other healthy bacteria may yield the greatest precision probiotics benefit.
A proposed mechanism of action is associated with the recolonization of the intestinal membrane by adhering to human mucosal cells, displace harmful bacteria while establishing new friendly bacterial communities. Select probiotic strains are documented to produce antimicrobial substances active against pathogens, including Salmonella species, Clostridium, E. coli, and others. You can see the Kirkman Laboratories Guide to Intestinal Health in Autism Spectrum Disorder, 1981. The new line of defense controls a range of GI disorders, including functional bowel problems. A key to improving gut health healing is enhancing the bioaccessibility utilization of nutrients. Recent research cited in the Autism Research Review International 2024 likewise supports the impact of probiotics for individuals with ASD. As with our homeopathic remedies, a meta-analysis of probiotics conferred significant benefit for clients after 3 months of use. Similarly, gains were observed for participants above 10 years of age as well as below. Personalized treatment approaches were again also recommended.
More good news. Use of Bacteroides fragilis for 4 months for children with ASD, especially those under 4 years of age, resulted in improved scores on several tests geared to autism: the Autism Behavior Checklist, Autism Rating Scale, Social Responsiveness Scale, as well as measures of GI symptoms including diarrhea, constipation, abdominal pain, reflux, and indigestion. Note a third set of studies pointing to a 3 to 4 month interval before observing biological intervention benefit. Underscoring this possible role for supplementation, other researchers have reported significantly high correlations between GI symptomatology and autism. Finally, the Lin group noted a significant post-intervention increase in abundance in healthful bifidobacterium. In sum, Dr. Frank and I hypothesize that probiotics may effectively open the door for environmental interventions such as applied behavioral analysis, pivotal response training, and sensory motor integration therapy. The client's team can select the best fits. The rationale that a child will benefit synergistically from advances in both biological, internal, and behavioral, external realms is raised in one of my earlier papers. Here we posit that homeopathy helped set Andrew, diagnosed with early onset autism, on a new developmental trajectory. Nature supporting nurture. A case reported by a state university school of medicine indicated very substantive gains by female toddler twins with autism receiving multiple overlapping biological and behavioral therapies. Widely used autism evaluation instruments reflected pre-post changes in function meeting criteria for putting aside neurodivergent status for one of the twins. Autistic recovery can be centered upon healing a permeable, leaky gut, a dysfunctional, dysbiotic, inflamed microbiome, nonetheless regrettably tasked to produce about 90% of neurotransmitters that bear directly upon brain function. The gut-brain axis, behavior, and cognition are held hostage. Therapies that reduce GI inflammation and enhance the bioaccessibility and utilization of nutrients will most likely set the table for systemic improvement and environmental opportunity. Mitigation of frequently reported GI disorders, diarrhea, constipation, abdominal pain, reflux, and digestion, should allow individuals with ASD to fit more comfortably and benefit more consistently from environmental programs. Internal restructure of the enormous bacterial gut community through biological modification can be charted not only by changes in adaptive, maladaptive behavior, but also by laboratory analysis of abundances and diversity of healthy versus unhealthy bacteria. The potential impact of first altering a dysbiotic microbiome as a setting event can be captured by till the soil before you plant the seeds.
Behavioral setting events for biological interventions. It's common, if not universal, practice for therapists treating anxiety, depression, or other disorders to recommend exercise, time outdoors, or other forms of activity or stimulation as an initial part of a therapy regimen. Exercise is one component of modulatory therapy aiming to stimulate the microbiome in order to improve gut health and well-being. There's a study out of Yadov and Chauhan 2021 that's kind of important for that. In parallel, environmental modifications may importantly set the stage for biological changes by increasing bioaccessibility or utilization of nutrients. So healing is a relationship with nature. Relationships are never one-sided. Relationships are an intelligent and creative design for mutual support. If a bodybuilder wishes to create more muscle, she needs both a biological setting event, such as increasing protein in their diet with improved digestive ability, as well as a behavioral setting event, such as using a well-equipped gym. Either event alone may help in a limited fashion or be unsuccessful. Use it or lose it. Both biological and behavioral together creates dramatic results which are easily recognized in magazines showing pictures of our star performers. Use or behavior tells nature where to put our resources. If we work out only the right arm, then muscle builds unevenly, leaving our left arm weaker. Resources are utilized and built where there is need and use. If we want specific changes, then we need to promote in a balanced fashion both the biological resources, biological setting events, and behavioral or environmental setting events together, or results are limited and possibly unsuccessful. Both setting events, biological and behavioral, are a creative relationship design. Need will always be individualized for the muscles, bacteria, minerals, vitamins, and behaviors wishing to be developed within each specific child or adult. Some may have enough biological resources and only need behavioral intervention. Some may have behavioral responsibility and only need biological intervention. Both being improved can create greater results all around, and most will benefit from both, like any bodybuilder benefits from both. A final consideration. This article has highlighted probiotics as a frontline biological modification. Probiotics were part of perhaps 20% of the homeopathic plan, but to date there is not independent assessment of other remedies in Andrew's improvement, such as cod liver oil as a healthy fatty acid transporting minerals in the body, alfalfa loaded with vitamins and minerals available in tincture, coffee accruta for improved sleep, and together with CNET checking self-stimulation, especially during acute events. In this light, we may appropriately ask which elements or combination of elements led to the cessation of pica. Importantly, this raises some tension between an individualized approach to treatment and any attempt to standardize. One path forward is to employ the more generalized approach first, such as probiotics. Physician, dietitian recommended changes in diet and/or supplementation can be added stepwise if warranted. If results are still unsuccessful or less than successful in accordance with individual differences, seek out homeopathic services from a homeopathic practitioner, move from a more standardized approach to a more individualized approach pending results. We wish you all the best.
Dr. Frank and I hypothesize a two-way street for the role setting events may play in autism treatment and recovery. Historically, therapy choice has remained on one side of the street or the other without recognizing the potential of setting events or combining biological and behavioral approaches into a synergistic model. Biological events may first open the door for environmental interventions if we till the soil before we plant the seeds. Environmental modifications may similarly unlock bioaccessibility utilization for biological interventions. Introducing both biological and behavioral modifications in combination may be the best option. Giving the body all critical resources at our disposal and then trusting the body to make optimal use of them is indeed worth consideration and further study. We throw down the gauntlet. And we thank you very much for the opportunity to present this paper.
For this opportunity. My name is Sanjala Sen, and I'm a faculty at Winston-Salem State University in North Carolina, USA. I am in the School of Health Sciences, Occupational Therapy Department. The topic of my presentation today is effectiveness of neurovision educational modules on knowledge and confidence. Let me put this. To introduce this topic, I wanted to give a little background. We live in the southeastern part of the United States, which is also known as the Stroke Belt. due to a higher incidence and mortality rate of strokes. 65% of these strokes, in addition to having physical and cognitive issues, can also have visual deficits. And occupational therapy practitioners that address visual impairments, in addition to physical and cognitive abilities, can help these clients make significant functional improvements during the first 6 weeks of therapy. So this is the evidence behind my presentation today. The purpose and research questions of the small study was, the purpose of the study was to examine the perceived effect of neurovision educational modules on confidence and knowledge for OT practitioners so that they could address this vision impairment post-stroke at an inpatient rehabilitation facility. And our research questions were, we wanted to see what was the current knowledge and confidence of these practitioners, and then what was the practitioner's perceived experience after the completion of this educational modules. I do want to give a little background of why we did this study. So the inpatient rehabilitation facility, which is close to our university, it is also a comprehensive stroke center, and the patients coming there are a lot of strokes and brain injuries. And in addition to all other problems, they have visual deficits. The practitioners, the occupational therapy practitioners, occupational therapy, by the way, which is an allied health professional treating, giving rehabilitation in acute care, inpatient rehab, outpatient, all different settings. So the OT practitioners from there reached out to us saying that though they had some knowledge of these vision deficits in stroke in their program, they were not confident about treating them in the acute care setting. And they reached out to us thinking, will you all create some educational modules so that we address these problems early on? So that is what a small group of my research study students and we created those modules, which I'll talk to you about a little later. And then we wanted to see what was the impact of this. So that was a little bit of a background for this study. So our research methods were, a participant demographic, it was small. We started off with a larger group, but because of various reasons, we could not. So it was more like a pilot study. So we had 6 participants, 5 females and 1 male, age ranging 20 to 60. And the experience range as an occupational therapist ranged from new grad, which no experience, to maybe 18 years of experience, but in different settings. We did do a mixed methods design. We tried to collect quantitative and qualitative. The quantitative was the pre and post knowledge and confidence survey, which we had created using a lot of evidence. And then the qualitative data was developed from exit questionnaire to capture participant opinions. The way we created this vision modules, we took the support of BIVABA, which is a brain injury visual assessment battery for adults. We also took the help of a certified vision specialist. So once we created the modules, we asked that expert to look over it and see whether we were on the right track. We used evidence-based research on how this, which were the best assessments and interventions. And these modules were self-created education modules. And then we had surveys and questionnaires. And this is a little flow chart of the same thing what I talked about. So we had to do an IRB through our university, and after we got the IRB, we had a contact person at the hospital, and they sent emails and got the consent forms, and we sent the demographic survey, and then we had modules, education modules 1 and 2. And email reminders had to be sent. And then after they had completed the modules, which was a self-paced module, they had to fill up a post survey, an exit questionnaire, and also take like a small quiz to make sure that they had understood the modules. And then we did the data collection analysis and then presented at our conference. So our research methods, we used the analysis tools we used were Microsoft Excel and Forms. We analyzed and compared using descriptive statistics, and the research platform was a virtual self-paced format. So once we did the modules, we sent it to the therapists and they could do it at their own pace, but we had given them a certain time limit to complete this. I want to talk a little bit about the education module. I know that's not that's the main thing I had planned to present on this, but because of the time limits, I had to do outline only. So the education module 1 created, it was an overview of the eyes. Like I said before, our therapists get some information or some education in school, but not a whole lot. So we created PowerPoints for overview of the eye, all the cranial nerves, especially the ones that supply the eye. Then functional impacts on visual impairment post-stroke. So what happens when a client has all these issues and how does it impact them functionally? And then, of course, the stroke prevalence and facts. Our educational second module had the crux of our material. So this contained the topics were visual perceptual testing hierarchy. So what we realized was many occupational therapy practitioners do not know where to start from. So we had made a neurovision decision tree. Like if they have this problem, then you go to this next step. If they have that problem, what you do? So that helped them and we included in that. Then we talked about all the functional deficits that could occur because of acute stroke or brain injury, neurovision deficits. Some of the assessments we included with videos was visual acuity. So how do you test visual acuity? How do you test the visual field? We did a confrontation test, which is with one eye closing, you see which eye they have. We did a test for diplopia when they have, this is a very common problem in stroke patients. They have diplopia and they are not really able to tell, but that impacts their function. So how do you test for that? And then we did even visual tracking. So there were many topics and all of these, we created videos for each one so that they could go and watch those videos as many times as they wanted. After the assessments, we also did occupational therapy-based interventions. So this partial occlusion for diplopia, this is a very quick method which we can do in the acute care itself. Instead of them waiting to go to a neurooptometrist and get prisms and glasses in their for frosted glasses for diplopia, but there is a very simple method which we can do partial occlusion. So with a transport tape, you can put it on there. You have to test it before which eye has that, and then put it on the tape, and that disappears. We also provided strategies for functional scanning, a lighthouse technique, which is when they have lost vision in one eye or parts of one eye, how do they navigate the environment? So being like a lighthouse from, going from one area to the other and scanning. We did anchoring technique. We realized that clients were not able to read because they were losing parts of the vision there. So anchoring technique where we had colored tapes from one end to the other, and they had to read from one end to the other till they reach the other tape so that they are not missing anything. So the educational second module contained a lot of important information. Our quantitative data for the surveys we did pre and post, these were the questions we kind of wanted a assessment on. So knowledge to implement assessments. It started off, so if you see the blue one, that's the pre-survey, and then the light blue one is the post-survey. So the aggregate of that, it started at 3 and then improved to 4.3. The confidence to select the proper assessments increased from 3.16 to 3.83. Then the knowledge to implement the interventions increased from 3.5 to 4.3. Confidence to select interventions also had a considerable increase. Knowledge to provide the interventions had a lot of increase from 3 to 4.16, which was the main goal of the therapy, what we do in inpatient rehab. And then the confidence also increased from 3 to 4.33. The quantitative data, the average response of pre-surveys for all 6 statements was 3.16, so between neutral and somewhat agree on our Likert scale. And then the average response for post-survey improved to 4.15, so now was between somewhat agree and strongly agree. Participants had the largest mean increase, 44.4%, in both their knowledge to implement assessments and confidence to provide interventions for patients with neurovision impairment. So that was the goal, where they have the knowledge to decide which assessment to do, and once the confidence to provide the proper evidence-based interventions. All participants perceived a mean increase in knowledge and confidence after completing the educational modules. The qualitative data we did with a code book, and coding was done by each of our research group, and then we arrived together by discussion with themes, and then these were some of the themes we chose. evidence-based, that the modules were evidence-based, they were informative, and they were organized. There were some others there that were very creative, especially the videos. They said they were very creative because they were created by our research group and very pertinent and helpful for them. So some of the qualitative data impactful quotes I would like to add. Participant 3 said, I believe the educational modules will help with my future interventions because now I have a basic toolkit of assessments and interventions to utilize for the most common visual deficits with our patients. Participant 7 said it was a very helpful and good review. So some of the participants who had experience, even for them, it was a good review. They appreciated the detail and breakdown on topics, and they said it was very applicable to inpatient hospital setting. Participant 6 said it was a good way to give a reminder and clarification of different options for assessments and interventions. So they felt that they got more options to do different interventions in the inpatient rehab setting. For discussion, the educational modules we thought were perceived as a positive experience, improved knowledge and confidence for the OT practitioners to provide these assessments and interventions in a comprehensive stroke center. And we thought that future research should be followed up with the study group to assess retained knowledge and confidence 1 year post-program implementation to see whether they were still following it or whether they had any changes after they implemented the. And for greater impact, a larger sample size would be encouraged, and maybe including many other inpatient rehab centers from the city. We did have limitations, a lot of limitations. It was a small sample size. Though COVID-19 had already gone, but the healthcare profession suffered a lot for a long time. So we had limitations such as the visual format and healthcare workers burnout. So we started off with a larger group, but then some of them left and some of them were just too busy to do it. So we did end up with a smaller sample size. Busy practitioners and communication difficulties, only one person said where they were having a hard time accessing some of the videos. The significance of this for occupational therapy is the improved confidence and knowledge of the OT practitioners is significant because early assessment of visual impairments post-neurological impairment leads to early intervention. And this can have a probable impact on general rehabilitation where visual function can be increased. So like I said before, many of our clients in the comprehensive stroke center with vision deficits are not treated till they go home, and then they get a reference to a neuro-ophthalmologist and then have to go through that expensive treatment of getting the glasses with prisms and all, which can take a very long time. And in the meantime, their function is impaired. So some of this early identification and early assessment, early intervention can have impact on their function. So in conclusion, the qualitative and quantitative data indicated that the educational modules improved the OT practitioners' knowledge and confidence in treating visual impairment post-stroke. And if you see on the right-hand side, I have one slide of 2 of my students doing the near vision acuity testing. That was a video of they did of each testing. They created videos. And these are our references, some of our references. Like we said, we did use the BioABA and the hierarchy of Mary Warren, which she's the guru of vision rehab in the occupational therapy in the United States. And so we used a lot of her resources too.
So my research has really been focused on understanding what makes the brain resilient. One of the case studies that have always struck me as very interesting is this case of Jonathan. So what you will see in this video is that despite this patient, Jonathan, being born without his cerebellum, the hindbrain structure in the back of his brain, he can walk fairly normally. You can see that he can coordinate his movements and do complete even fine motor skills such as locking his door. And this struck me as very fascinating that without having a very important motor structure within his brain, that movement can still be undertaken. And one of the main reasons for this is based on the timing of cellular loss. So if we were to examine this case, for instance, Jonathan was born without a cerebellum, which means that his brain was developing and making neural connections in the absence. And because the structure was gone from the start, the brain was able to adapt to make new connections so that his movements can be largely preserved. And we notice that this is a timing, or timing is very important, because if we look at instances where the brain is aged, there are different conditions that can result. So for instance, the same structure that is missing within the case of Jonathan can be impacted by different diseases or conditions such as stroke. And you can see here in a patient that is 80 years old. So based on this timeline that I'm showing, this condition is occurring after all the neural connections have been developed and formed. Once this brain structure is disrupted, we see severe motor impairments. And so the brain is not able to adapt or be as resilient as it once was. And so this question of how can we understand brain resiliency and its timing really has fascinated me and has driven my research. My research question being, can studying circuit development save movement? And in my studies, I have looked at various structures. So in Jonathan's case with the cerebellum missing, I have also focused on this area of the brain. Particularly in my studies, I have studied a loss of function mutation that spontaneously occurs in a mouse model of ataxia, dystonia, and tremor. Ataxia refers to the motor incoordination between limbs. Dystonia can be common within childhood and also arise later in life. And this refers to abnormal muscle contractions that can result in abnormal postures. And then tremor, which we see in, for instance, Parkinson's disease patients or sometimes older individuals where there is an oscillatory shaking that is uncontrollable. And so all of these different symptoms can be resulting from disruptions to the cerebellar circuit. And in particularly, I studied a model where the loss of the carbonic anhydrase 8 gene results in these phenotypes. And besides the cerebellum, which is highly important for motor coordination, as we've seen in the previous slides, I also have studied the basal ganglia and more specifically the striatum by studying a conditional knockout mouse where we engineered a loss of function mutation in the torsin 1A gene to create a mouse model of dystonia, or that condition, the neurological condition where there's abnormal motor contractions. And so just to show what these mouse models look like before I go into the data, you'll see on the left side under the cerebellum, a control mouse versus on the right side, the ataxia mutant mouse. And you can see that the mice exhibit a more wobbly gait and does not have as smooth movements, mirroring what we see in humans. And under the striatum, our mouse model has abnormal motor movements, particularly this abnormal limb clasping behavior. So in control mice, when they are tail suspended, these mice typically will not have their limbs come together. But when we delete a dystonia gene, we see that the mice clasp a lot, particularly starting during development, which mirrors what can happen in the human disease where there could be developmental onset. And so what I would like to talk briefly about is how an example of my studies in the cerebellum, an example of my studies in the striatum can inform future avenues of therapies to pursue. Because both of these conditions, particularly ataxia and dystonia, struggle with having effective and consistent outcomes therapeutically. And so first I would like to discuss my findings when I looked at the cerebellum during development. So a little information about the cerebellum and important cell types. So the cerebellum has a canonical circuitry that is repeated throughout the structure. In pink, you will see this large elaborate cell called the Purkinje cell. And this is the principal cell type of the cerebellum and communicates information from the outside world to downstream structures. Particularly, information will be conveyed to the thalamus, the spinal cord, and the brainstem to elicit movement and particularly help with motor coordination, being able to coordinate our steps, for instance, during walking. And in the mouse model of ataxia that I previously mentioned, this particular cell type started early in development. The Purkinje cells are particularly affected. What you'll see in magenta is the carbonic anhydrase 8 gene, which is abundant in the Purkinje cells within the cerebellum of control mice, but within the loss of function mutant, we don't see any protein expression, and this actually results in calcium defects within the cerebellum, particularly the Purkinje cells. And as a result of losing this protein, we performed electrophysiology and found that these ataxia mutant mice have abnormal neuronal firing. So normally in control mice, when we measure neuronal activity from the cerebellum, we'll see consistent action potentials. Each of these lines represents an action potential, and it will be consistent firing. But in our mutant mice, we see that there are a lot of pauses and more bursty firing within these animals. And we did find that if we systemically administered a drug to help reduce the pausing of firing in Purkinje cells, which we can see here, we go from a more bursty firing pattern to a more consistent firing pattern, reminiscent of what we see in control mice. We find that this does have implications for behavior. Particularly, we looked at rotarod behavior, seeing how long the mice can stay walking on a rod that accelerates faster and faster. And normally, control mice can stay on the rotarod close to 300 seconds, while the CAR8 mice normally fall within 50 seconds. And there is some significant improvements in motor function when we do improve Purkinje cells. Although this improvement is not near controls, it does indicate that at least the Purkinje cells are involved in motor disruptions to some degree. And so knowing this, I strive to understand, well, how does the Purkinje cell develop within the cerebellar circuit? And so I turned to histology first to see whether or not there are any gross anatomical defects. And I sampled throughout the lifetime of a mouse, starting at 5 days old, all the way through adulthood. And I found that at the beginning of cerebellar development, the mutant mice have significantly smaller cerebella than the control mice. But by 20 days old and on, there are no significant alterations or size deficits that I can quantify. And when we look more closely at what can be contributing to this rescue that we see in size, I stained for Ki67, or a proliferative cell marker within the cerebellum. And so I'm looking at the number of cells proliferating within the cerebellum. And I found at P5, there is a reduction in proliferation, which would make sense and aligns with our findings that there is a smaller cerebellum. But by the time we reach the end of cerebellar development at P20, we see that there is equivalent proliferation with increased proliferation compared to controls at P15, so 5 days earlier. And this indicated to us that although there was a transient delay or decrease in proliferation, proliferation does catch up and actually extends past its normal time window within these mice. And this could have significant implications for cerebellar circuit functioning because any simple delay within circuit development can cause miswiring. Particularly, these cells are proliferating, synapse onto Purkinje cells, and so having its proliferation extend past this normal developmental time window could cause or contribute to that bursty firing that we saw before. And despite these developmental alterations that I previously found to resolve, there are anatomical deficits or changes that do not resolve over time. We found through electron microscopy, when we looked particularly at the nanoarchitecture of Purkinje cells, we looked at the mitochondria, which is very important for calcium regulation, which we know based on the carbonic anhydrase gene. Its deletion does cause calcium defects within the Purkinje cells. We found that the CAR8 wattle mice have significantly fewer mitochondria within their Purkinje cells, and their mitochondria are significantly larger. And similarly, when we looked at the putative context between mitochondria and the endoplasmic reticulum, which is important, these contexts are important for calcium regulation within the cytoplasm and buffering within the cell, we found that there are significantly more ER in contact with mitochondria in the mutants than in the controls. And so these studies have really helped me understand better what is happening to the cerebellum as it's developing, and using these conclusions, I wanted to see whether or not I can test a therapy based on specifically my developmental findings and see whether or not that can improve motor symptoms. And so in summary, for the cerebellum, I found that within this mouse model, there is abnormal electrical firing, there is miswiring that is occurring during development, and our data from the electron microscopy implies that there might be organelle dysfunction, although we are pending biochemical assays to confirm this. But based on these symptoms, I decided to try a therapy that can address all of these findings. So a therapy that will help alter the electrical activity of Purkinje cells, one that will overcome any miswiring defects, and then also has evidence of altering metabolism within the cerebellum. And so I decided to try deep brain stimulation, which is important for or can help address all of these different symptoms. And I combined it particularly with exercise, because also exercise can help with neuronal function. And so when I tried this therapy, I found what you'll see is when deep brain stimulation is off, that the CAR8 wattles mice move very wobbly and they fall off the rotor rod very quickly. Within 20 seconds, this mouse would fall off. But once deep brain stimulation targeted to the cerebellum was on, this mouse was able to walk on the rotor rod for up over 100 seconds. And you can see that its coordination drastically improved. And so a very similar situation was found when I studied the striatum. I found that when we look at a particular cell type, particularly in the striatum, there is a subtype of neurons called the cholinergic interneurons that are hyperactive. So we see that they're hyperactive starting later in development at 17 days old and on, after they start to exhibit dystonia-like behaviors. And we know that if we administer antimuscarinics that are administered in the clinic, that these mice will not significantly get worse their motor behavior. And so I wanted to also look at this cell type during development to see whether or not we can come up with a therapy that is more tailored and more effective, because antimuscarinics can have very adverse side effects and are not always effective. And it might be due to its systemic administration. And so briefly, I found that through immunohistochemistry and different synaptic assays, that inhibitory synapses within the cholinergic neurons are reduced early on in development at P14 before behavior manifests. But by adulthood or young adulthood, we see a drastic increase in inhibitory synapses. And so I wanted to do the same thing as I've done with the cerebellum. Could we use what we've learned during development to help develop a therapy? And so That is where my research is currently taking off, looking at whether or not we could tailor therapies based on our developmental findings. Some preliminary evidence suggests that the inhibition that I see that is increased after the behavior it manifests may be actually more of an adaptive response to help try to recover behavior rather than a maladaptive behavior. So what you'll see in this immunohistochemistry slide is that when we reintroduce the dystonia genes specifically to our cholinergic interneurons, we see even more inhibitory synapses, and this corresponds to increased behavior. And so that is where my research is currently at. We are going to continue to address the question, how do development motor circuits adapt? And particularly, we are focusing on in the absence of genetic mutation, so we can determine whether there are basic universal mechanisms in the brain so that we can better develop therapies for these movement disorders that lack effective therapies. And with that, I would...
Slide number 1, you can see the name of the article, where it was published, how to cite it, and the abstract, and also the keywords: Socratic method, Socratic dialogue, Socratic questioning, philosophical midwifery, cognitive therapy, and cognitive behavior therapy. Okay, we're moving to the second slide. Okay. One moment. I'm sorry for the technical issues. Okay. So Socrates are the foundations of the method. Socrates is arguably the most influential philosopher in history. He was born in 469 BC in Athens. He lived during the golden age of Pericles, when Athenian democracy, art, and philosophy flourished. Pericles himself praised Socrates as a great soldier of the Peloponnesian War who loved his city and fought for it with valor and honor. Though trained as a stonemason and sculptor by his father Sophoniscus, Socrates abandoned his career and dedicated his life to dialogue, mainly in the agora, or agora in Greek accent, the marketplace at the outskirts of Acropolis, engaging especially with the youth of Athens. Let me see if you can see the slide. Can you all see the slide? Okay. Let me see. Okay, we can see the slide. All right. One moment. Okay. Socrates never wrote anything. I'm sorry, one moment, I have a technical issue here. Socrates never wrote anything. What we know comes primarily from Plato's dialogues, whose works shaped Western philosophy. Socrates taught Plato, and Plato taught Aristotle, who later taught Alexander the Great, continuing situating Socrates as at the beginning of a major intellectual lineage. His mother, Phanerete, was a midwife, and this inspired Socrates' idea of philosophical midwifery, helping minds give birth to ideas. Socrates was married to Xanthippe, much younger but very difficult, ill-tempered, always critical and argumentative woman. They had 3 sons, Lampocles, Sophroniscus, and Menexenus. Once Socrates and Plato reached Socrates' house and sat under a tree to have a philosophical discussion. Xanthippe saw them from the window and came out of the house asking Socrates if he brought home some food from the marketplace. Socrates didn't bring anything, so she poured a pitcher full of urine on his head. Plato asked him how he could stand her. Socrates replied that if he can deal with her, he can deal with everybody. He was truly grateful of her as a great challenge and good practice of patience, wisdom, criticism, conflict, debate, and argumentation. Later on, he left her for the younger and sweeter Myrto, his second wife. Can you blame him? I don't. While Socrates became known for his relentless questioning, he was not universally admired. Aristophanes portrayed him as a dangerous sophist in his comedy Clouds, and a group of accusers, Miletus, Anytus, and Lycon, charged him with first, irreverence towards the gods and introducing new deities to the city, second, corrupting the youth. These charges led to his trial and execution. His commitment to truth and virtue was so strong that he refused to escape when Crito and his friends offered to bribe the guards. As we learn from Plato's Crito, he drank the hemlock, remaining faithful to the laws of Athens, as described in Plato's Phaedo, where he said farewell to his students, but first spoke about the immortality of the soul. In the left bottom picture of the slide, you see his prison in a cave beneath the Acropolis hill with 3 rooms. It was said he was kept in the first. I don't know if you can see the slide. Okay, it's this one here. All right, so we're moving to the third slide. Okay. Today, Socrates' principles continue to influence educators, counselors, therapists, and legal and medical training programs. The essence of the Socratic method, dialogue, inquiry, and guided self-reflection, is still used across disciplines. His metaphor of being a gadfly emphasizes his role in provoking self-examination. This relational, supportive, and trust-based environment resembles a therapeutic relationship in cognitive therapy, CT. Socratic questioning, asking, what makes this a problem for you? Or what have you tried already? Is foundational in many counseling approaches. In the third slide, we will talk about Socratic ignorance, introspection, and the inner voice. Cognitive therapy CT is particularly effective for OCD, obsessive compulsive disorder, PTSD, post-traumatic stress disorder, and even schizophrenia. Like Socrates, CT, cognitive therapy, emphasizes self-awareness and identifying faulty thinking. Socrates spoke of an inner guiding voice, the daimonion, not to be confused with demon as we know it in Christianity or other Abrahamic religions. Back then, it meant a deity, not necessarily evil. Whether understood as conscience, self-talk, the higher self, or something akin to Jung's collective unconscious, it represented the moral and intuitive inner direction. His accusers viewed this as suspicious, but for Socrates, it was an inner ethical compass. A key Socratic concept is aporia, the recognition of one's ignorance. Socrates approached dialogue by claiming he knew nothing, inviting students to articulate their own views and guiding them logically. He charged no fees and saw himself not as a teacher, but as someone helping others uncover knowledge always within them, a view that aligns with Plato's theory of recollection and the world of forms. This method parallels inductive reasoning and the monitoring of thoughts in cognitive approaches. We're moving to the fourth slide. One moment. Cognitive distortions and the pathologos. Grimm's introduced the term pathologos, meaning an abnormal or distorted way of thinking. Aaron Beck, founder of cognitive therapy, identified similar distortions. These include catastrophizing, selective abstraction, personalization, labeling, magnification, minimization, overgeneralization, and dichotomous or polarized or black and white thinking. Socratic questioning is remarkably similar to Beck's examination of evidence. Both rely on self-dialogue and critical reflection. Beck listed several inner conditions for this process: rationality, teachability, clarity, and avoidance of error. James Overholser is a leading figure in integrating the Socratic method with CT cognitive therapy. His major works include the Socratic method in psychotherapy, treat Socratic dialogue as a form of guided discovery. I have to say here at this point that I had the honor to be a peer reviewer of this book by Columbia University Press. The therapist uses open-ended, non-judgmental questions without imposing interpretations. This mirrors Socrates' belief that knowledge leads to moral insight, though Socrates also warned that skill alone does not guarantee virtue. Moreover, Socrates often taught at his most favorite spot of the Agora, the cobbler shop, the shoemaking shop of his good friend Simon the cobbler. Inspired by the artisans he hung out with, Socrates often compared technique in questioning and philosophical inquiry with craftsmanship. That means mastery or artistry. Socrates believed and agreed with his students that craftsmanship or expertise or professional skill may lead to knowledge. However, having knowledge doesn't necessarily mean that it leads you to morality and wisdom. Likewise, professional technique in therapy doesn't necessarily lead the client to morality and wisdom. Historically, the Socratic method entered education through thinkers such as the British philosopher of education Leonard Nelson, who created individualized teacher-student questioning, emphasizing moral development, emotional intelligence, self-knowledge, and awareness of one's environment. The German philosopher of education Gustav Heckmann later expanded this into group dialogue, which I agree can be applied in group therapy. We're moving to slide number 5. Okay. Heckmann's 6 group dialogue measures. Heckmann proposed 6 measures for Socratic group dialogue. Content impartiality, work with the concrete, mutual understanding, stay with the question, strive for consensus, and facilitator interventions. When integrated with cognitive therapy, Socratic dialogue helps clients uncover repressed or denied thoughts and emotions, building metacognitive skills, that is awareness of what one knows and does not know. This resembles Jung's transcendent function, which brings unconscious material to consciousness. Compared to psychodynamic approaches, however, Socratic and cognitive methods are typically faster, more affordable, and more direct. We're moving to slide number 6, and we have 2 examples from Plato's dialogues. Two examples from Plato's dialogues illustrate Socratic techniques: Polus and Callicles in the Gorgias. Polus accuses Socrates of dishonesty and deliberately twisting arguments, but Polus' true challenge is his anger and resistance. Socrates helps him see that he contradicts himself and that his emotions, not his search for truth, drive his arguments. By guiding Polus to acknowledge his own inconsistency, Socrates enables him to become a witness against himself. That's a Socratic paradox. Polus ultimately recognizes that he has acted unjustly and that injustice harms the person committing it. Callicles, like Polus, begins with confident, egoistic claims. He believes doing injustice is preferable to suffering it. But through dialogue, he realizes his position contradicts itself. If repeated injustice causes suffering, then suffering must be preferable to committing wrongs. His resistance dissolves into silence and shame, a recognition that his anger and pride have misled him. These patterns, arrogance, resistance, and emotional reactivity, are common in modern relationships between teachers and students, parents and teenagers, colleagues and friends. Socratic questioning remains a powerful tool for diffusing such conflicts. Now we're moving to slide number 7. One moment. We have here a modern example by Padensky and Stewart, her client. A temporary illustration is Christine Padensky's Socratic counseling dialogue with a client named Stewart, presented in my article's appendix. Stewart struggles with jealousy, low self-esteem, and comparisons to his brother's seemingly perfect life. Through careful questioning, Podensky helps him articulate what would make him feel like a better father and a happier person. She models the therapist as a facilitator, guiding without judging, interpreting, or imposing answers. Empirical work is emerging in this area. One of the few studies is by Grims and Juliana, Pierre Grims and Regina Juliana. Grims was a French philosopher. He passed away recently. And Regina Juliana is a clinical psychologist. In the research on philosophical midwifery, their approach called the dialectic mode of rational psychotherapy, DMRT, and its clinical application, GDMRT, produced moderate but significant effects, R equals 0.655, showing a promise in addressing anxiety, self-blame, hostility, denial, and worry. Clinical evidence also suggests that Socratic and cognitive approaches outperform psychodynamic ones in certain severe conditions. My own practice in vocational rehabilitation counseling uses an integrated and eclectic approach, drawing on Socratic cognitive and analytic techniques adjusted to the needs of each client. And we're reaching the conclusion. I'm sorry, one moment. Okay. To conclude, the Socratic method aims at self-awareness achieved through questioning and guided reflection. Its cognitive nature aligns strongly with Beck's cognitive therapy, and Overholser's model demonstrates how the method becomes a counselee-directed process. Socrates' metaphor of midwifery shows the role of the teacher or therapist, helping ideas be born through the client's own reasoning. Socratic aporia, professed ignorance, allows clients to discover contradictions in their thinking, leading to insight and transformation. As Jung's transcendent function brings unconscious content to consciousness, Socratic questioning brings denied thoughts, emotions, and behaviors into awareness. While Jungian therapy is deep and symbolic, Socratic and cognitive approaches tend to be more direct, efficient, and cost-effective. Overholser emphasizes the need for more empirical research, but early findings include those of Grimm's point to meaningful results. Ultimately, integrating the Socratic method into education and counseling fosters self-knowledge, emotional insight, independent thinking, and autonomy. It remains a powerful tool, ancient in origin, but profoundly relevant in modern cognitive psychotherapy. I have some slides here with the references. I have two pages of references. And thank you.
In this presentation, I want to address a painful paradox. The stigma surrounding mental illness often causes more suffering than the condition itself. I speak not only as someone who has recovered from a bipolar diagnosis, but also as someone who spent over 20 years working directly with people labeled as mentally ill. I stood between professionals and clients and I saw both sides. What I learned is this: many of the problems attributed to mental illness are in fact created, sustained, or exploited by those considered mentally healthy. People without diagnoses are rarely questioned, even when they manipulate, control, or abuse others. Meanwhile, those with a diagnosis lose their voice, their credibility, and often, their right to be heard. When I advocated for clients, I often heard, "Why are you listening to them?" This wasn't just a comment, it was a worldview. It reflected a deep cultural assumption that a person with a psychiatric label cannot be trusted, while those without one deserve our automatic respect. But the truth is uncomfortable. Many of the most harmful actions I witnessed came from people with no diagnosis at all. Yet they faced no stigma, only support. That is what this presentation is about, to question who is really dangerous, and why society chooses to protect some and silence others. My father had psychiatric issues. When I was 20, I was hospitalized in a psychiatric facility with depression and suicidal thoughts. At that time, there was no psychological support and no accessible information. The treatment was brutal: insulin comas, aminazine, sulfazine, and isolation. After I was discharged, a manic episode followed, and I was diagnosed with bipolar disorder. My mother, a physician, believed only in medication. Her motto was, "If something feels wrong, go get pills." But what exactly was wrong was never explained. The whole condition was a mystery. Mother accepted me only in depression and reinforced my self-blame. "Yes, but don't do it again." In doing so, she prolonged the depression. At one point, dissatisfied with my behavior, she had me locked up in the hospital under false pretenses. It was friends who got me out and told me to escape this kind of dependency. My daughter and I left. We moved to the other end of the country. Years later, we met our relatives again in the US, after the collapse of the Soviet Union. They refused to help with my daughter and even tried to have us deported, accusing me of deceiving the US government by claiming I was healthy. But I never believed my condition was an illness. I came to America hoping to understand it. The American caseworker said. Lincoln had bipolar too. Welcome to America. We broke away from the relatives and survived on our own, just the two of us. Those were hard 7 years, but it was a time of mutual support. My daughter accepted me in any state and helped during my depressions. Breaking down my self-blame with facts and logic, my symptoms lost much of their intensity. We worked, studied, and had many shared interests. We had good friends. We trusted and respected each other. Everything changed when my daughter got married. Her husband, a man raised under tight maternal control, wanted the same full control over his wife. I stood in the way. He began enforcing a ban on communication. My relatives reappeared. They overwhelmed my daughter with unpleasant stories about me, shaping the image of a crazy, toxic mother. My daughter began to experience depression. Then came mania. Hospitalization. At that very time I was recovering. Through work with a psychologist, through Jung's ideas, through dream analysis, I was beginning to understand the roots of my cycles. The symptoms were fading. When daughter's condition was being discussed in the hospital, I said sincerely, "If it's bipolar, I've been through it. I got through. It's possible." I didn't know that from the system's perspective recovery isn't allowed. For my daughter's husband, my words were useful in another way. He insisted the illness was lifelong and claimed my recovery was just the start of schizophrenia. She's denying the illness. That means she's sick. When my daughter started seeing a psychologist, I had hope. I thought she might find herself, gain autonomy from husband's control and learn to choose for herself. But what began instead was the worst version of separation. Not a path to individuation, but a campaign to purge the toxic mother. Behind closed doors, psychologists can do that quite well. And when the mother has a psychiatric label, contact is automatically unsafe. The person is presumed dangerous by default. For her husband, this was very convenient. And after 13 years of difficult, on and off relations, he succeeded in fully banning all contact between me and my daughter and grandchildren. Before that, my daughter was doing well with homeopathic support. But after that separation, a deep depression set in. And he forced her to begin heavy psychiatric medication, also convincing her that bipolar is forever. Then with the help of a friend psychologist he convinced her that I was an abusive mother and that she needed to cut me off completely herself. Learning that from someone else, I made a decision to say goodbye and part ways peacefully. When I arrived there, I found my daughter in a deep depression. We began to talk. I could see she was getting better. Her voice steadied. But then her husband appeared. He demanded she come home. She begged to stay. He didn't allow it. He was furious. I had never seen him like that before. A few days later, I received a call from the police. If you contact your daughter again, you will be arrested. You have bipolar disorder. You're not taking medication. He talked to me as if I was a criminal. I turned to lawyers, to organizations, to police itself. I did explain to the police the situation about husband control. The accusation sounded this way: his complaint against you is that you are causing problems when you are around his wife and he blames you for her behavior that he does not like. Thus you are controlling, albeit indirectly, her actions by your mere presence. I was blamed for my very existence and that bothered him so much. My daughter's husband held absolute power and enormous support, even from police. So I left the country. I'm not Lincoln. Living under a label that others actively weaponize, especially after freeing myself from the problem itself, felt like mental prison. Several years have passed. I forgot a time when I had bipolar disorder. But the subject is too serious to remain silent about. My mother, who is no longer alive, took my place in my daughter's life. My grandchildren, with whom I once had a close, loving relationship, now see me as someone terrible. But this isn't just a personal story. It involved people from every level of the system: psychologists, doctors, lawyers, police, and different kinds of organizations I tried to reach for help. And that raises questions. As someone who once lived with bipolar, who worked for 20 years with children and adults facing mental health challenges, I ask this. Who causes more harm or who is more dangerous, a person who washes his hands 30 times a day or a person like my daughter's husband, who is considered mentally healthy, but affected so many lives by his actions? Who is more dangerous, a person with a diagnosis, or the one without a conscience? Why the system on their side? My daughter's husband, raised under the control of his own mother, sought full control over his wife. Her bond with her mother, the closest person to her at the time, interfered with that control. He acted through the system, presenting the mother as a threat, using the stigma. The system, without proper investigation, supported his strategy of exclusion. The psychologists involved worked on so-called psychological separation, portraying the mother as an obstacle to the daughter's growth. They discussed her in absentia, without any attempt to hear the other side, assigning her qualities they deemed harmful to the client. The mother was not allowed to participate in these conversations. Instead of seeking restoration or balance, therapy became a tool to solidify the image created by the husband, thereby deepening the isolation. When the mother, exhausted from that struggle, tried to say goodbye peacefully and part ways, the husband used this visit to involve the police. He invoked her old diagnosis, formerly considered incurable, as a universal justification. Even peaceful actions were reframed under that label. The police, violating confidentiality laws, fully supported the husband's position. They ignored not only the mother's explanations, but also the presence of a witness. In this way, the exclusion was made official. The legal system offered no viable path either. Although a lawyer acknowledged the husband's control and emotional abuse, he refused to act. No organization proposed any protective mechanism. Thus, at every level, from psychologists to police to legal professionals, the system reinforced the destructive will of a person officially considered mentally healthy, but acting immorally. 1. View mental issues through harmful behavior, not diagnosis. A. Do not treat a diagnosis as a lifelong sentence. In my case, an old and no longer relevant diagnosis was used against me, as a justification for banning contact, without any regard for my actual behavior. B. Recognize calm abuse. The system failed to see the control and emotional suppression exerted by my son-in-law, even though I explained it clearly and logically. C. Using a diagnosis as a weapon must have consequences, both for individuals and institutions. The system allowed an ordinary person to weaponize someone else's diagnosis, and even actively supported this violation. D. Only licensed psychiatrists may assess danger related to mental illness. The police interpreted danger based on second-hand statements, without the expertise or legal authority to make such judgments. 2. Therapists must not act against people they've never spoken to. Psychologists discussed me with my daughter without ever inviting me to speak. They created an image and built therapy around it. This violates professional ethics. Anyone who influences another person's fate must listen to both sides. 3. Police should not get involved in family conflicts if they're not crime. The police must not act as a tool in personal conflicts when no crime has occurred. Such cases should be handled by a special body involving legal experts, psychologists, and mediators.